Good morning, everyone. Can people online hear me? People online hear?
Can hear you okay, no problem.
Thank you very much. Thank you. Thank you. Yeah, it was a bit.
I'm going to put this thing on.
I just want to start now.
Yeah.
Joe, Tommy's on his way. Good morning, everyone, and welcome today to the Adults and Health Scrutiny Committee. I would like to introduce myself. As I think some of you already know, I'm the chair of the committee, Jill Slocum. Just to let you know, there's no planned fire drills today. So if you exit the building through the main reception, if anyone's present requires assistance to the building, which will be me, we let the Gam Democratic Services know. The assembly point is at the grass outside the job centre, but I think we're going to be okay because I will be in the front. The agenda pack with papers is available via Modgov or directly from the council's website from the link which was sent to members. I'm requesting that members and officers turn off their microphones and videos, but please remember to turn on the microphone and video when you speak. This helps with any background noise and obviously quality. When I invite you to speak, could you clarify clearly who you are, the benefit of everyone's listening so they can identify. Can I also remind members to use the chat function just solely for committee business, nothing else, please. Genders are now viewed electronically. Can I request that all members and officers refer to page numbers as much as you can to clarify the points that you would want to raise. I advise members there has been a change to the running order of the published agenda. Item 1 will move to the end of the meeting, and item 9, progress on implementing the homeless rough sleeper strategy and action plan, will now be our first report. I apologise about this. We're going to try as hard as we can not to change the agenda in the future. This advise members that this is the last meeting of the committee under the current name. As on the 20th of May, it will be known as Adults Health Housing Scrutiny Committee, which I think we've been referring to that anyway, to be honest. So we have many guests in the room. Before I start, I'd like to welcome the members, people that have come. I'd like to obviously welcome Andy Heron, Gary Rysdale. Andy Heron, as we know, is the Chief Operating Officer of Somerset NHS Foundation, an important man. Gary Rysdale, Service Director, Occupational Transformation, NHS Foundation. We have also very many people online. Andy Miller, Divisional Director of Operations for Dorset Hospital, NHS Foundation. Christian Wigan, Assistant Director, Consultant Paramedic. Chris Turner, Assistant Director of Operations, Somerset. And Dr. Robert Whiting, Consultant Stroke Physician, Somerset NHS, which I think Dr. Whiting is here with us now, which is always better in person, but we do appreciate the others that cannot be here. So I just wanted to make sure that we obviously welcome you all. Welcome also to Alison Rosewell. He's Director of Localities and Strategic Commissioning. So I just wanted to make sure that everyone's aware that we have a nice team here. Our portfolio holders with us again, as always, and it's really important. So thank you very much. So now I'd like to hand over to Jack Lakovic. Which lovely name. Who's the governance specialist, to list any apologies. Thank you.
Thank you, Chair. Good morning, everyone. We have received apologies from Councillor Emily Palestone, expecting other councillors who are not here currently to arrive shortly. Thank you.
Thank you, Jack. Thank you. This is item 2 is to approve the minutes of the previous meeting in the 9th of April. I think they are here. So are you all happy that that's the true record? You've seen them? Everybody happy? Dissent? Thank you very much. Very much, thank you. Item 3 is item 3 is declarations of interest. This is where I invite members to declare any interest to make them aware. And also, as we all know, the list on the council committee members for personal interest as members of the district, city, town and parish is available for inspection on the website. So do we have any declarations? Everybody good? Public question time. We're welcome today public question time. And Mr. Ray Tosavin on the stroke report. So if you would like to come forward, please, and speak. Just come here, please. Thank you. And thank you very much for coming today.
Thank you, Chair. Ray Tostavin from Quicksilver Community Group and also a public governor of Somerset Foundation Trust.
You may sit. You may sit.
Okay. Our group has previously circulated a letter to all chairs of parish and town councils in East and South Somerset, expressing our deep concern as a patient group and as a community group on behalf of others about the pending closure of the Yeovil hyperacute stroke unit. I have sent a copy of that letter to the chair and I will leave it to her discretion as to whether that letter is disseminated, but it sets out very clearly why we believe that the pending closure of the HASU will be a very grave mistake. We have put a fairly detailed data analysis looking at the ambulance response times, and I think all the things that are happening in the HASU at Musgrove Park and YDH and at Dorchester will come to nothing if we can't improve the ambulance response times. It's the elephant in the room. Without addressing that, all the mitigating mitigating things of bringing better care will not happen. So I think we see a failure to implement and fully test out and embed all the mitigations, and some are referred to in Alison Rousel's report today, to address the additional travel time. It's a further massive risk to patient safety and their overall outcomes. So we believe that the closure of the Yeovil HASU has to be stopped to prevent the implementation of a flawed decision based on poor data analysis and modelling. The current focus of activity should be not on finding ways to close the HASU in Yeovil, but to improve it. I am not convinced. I heard from from colleagues on Somerset Foundation Trust earlier in the week that there will be mitigation put in at Yeovil to ensure that we retain an acute stroke unit. I fear that that may not happen in the long term. I hope I'm wrong. We want to keep our HASU. It serves hundreds of thousands of people. Many will be directly impacted, not just in our county, but in the border around Dorset, North to West Dorset. So I would urge you, when it comes to the presentation, that you scrutinise it. You do exactly what you did 2 years ago when you asked the Secretary of State to call this in. And I urge you now to keep asking those questions. We may not be able to change the outcome, and we want the best. Let me be very, very clear. I want to see fantastic stroke services in my county where I've lived for 35 years. And I wish the team at Musgrove Park and at Yeovil well. I want to see them succeed, but closing our HASU isn't the way to do it. Thank you very much.
Thank you very much for that. Now I'm just going to I don't know whether Dr. Robert Whiting wishes to respond to that or whether you wish to respond within the papers when we get to the agenda item. It's entirely up to you.
Thank you.
Very kind. We apologise that the letter was not given, as the speaker has said. Unfortunately, we've only told this morning. I've allowed the speaker to let you know his thoughts today. So that's why you have not had the letter. It's not an admin error. It's the fact that we were not advised early enough. But I'm sure when we get to the agenda item, the speaker will be very pleased with the outcome. Let's hope. Okay. Thank you very much. So now we go to Adults and Health Scrutiny the committee outcome tracker. As we know, this has been slightly difficult for many people to understand this, so I'm going to hand you over to Mr. Jack, if you don't mind me calling him that, so I don't get his surname wrong, and he's going to explain.
Thank you, Madam Chairman. The outcome tracker that was mentioned in the report is not there. The reason being is that we are working on unifying all the outcome trackers across the all scrutiny committees to look exactly the same, and the purpose also for have the same purpose, which is to be either addressing the members of the executive leads, and the relevant officers, such as the executive directors, and in this case also our partners, such as the NHS. I'm just putting showing the screen. The example of outcome tracker that I would like to share with you, which I would suggest for you to consider, is it's something like this. This is the corporate and resources outcome tracker that we use at that scrutiny committee, and you can see that the outcomes or recommendations that made by the committee are on the left side, including the date, and we also allocate which lead officer or member is responsible to carry on actions or updates. The recommendations are in the third field. The RAC status is then the last field, which actually gives an update what is happening with the recommendation. Has it been submitted to executive, or has it been for the relevant officers or partners, and what is the response as well. Helen, can we go down? You can see there, for example, when we did submit, when we considered the budget in January this year, we submitted all the recommendations from the committee as well as all scrutiny committees to executive, and then we received a response from the executive, which was submitted by the full council. And what we did with that, we appended to the document so members had a sight of it. We also did with there's another example, which is unreasonable customer behavior policy, where we sent the recommendations straight to executive and they considered at the meeting. This is the same approach we have for Children and Family Scrutiny Committee. We send the recommendations to the executive along with the relevant directors, and we receive the responses back, which we append then to outcome tracker. So this is something I propose for this committee as well to be considered in the future. I'm also saying that I presume I will be taking over the work of this committee as from now on, but I will make sure that all the outcomes that you make at the meeting, they're forwarded and sent to executive to be considered at the first appropriate executive meeting, or to relevant officers and also partners. Thank you.
Thank you. I think that does explain it very, very well. It's something we've wanted for a while. So I'm going to go to members now for any opinions, please. Councillor John Bailey. You have to press the side. I'm sorry, first. Press your side.
Right.
Yeah, you're in.
Can you hear me now? Oh,
Yeah.
yeah. Thank you, Chair. I mean, I think I speak for everybody else that we come to these meetings in order to achieve something for the residents of Somerset. But I'll speak for myself by saying that. And I think what I'm concerned about here, we're almost in the process of triumphing over outcome. And the fact that we don't have an action plan of some sort, which has been around for donkey's years, which says what's going to happen when, and I've seen these in other committees, I think should not delay us to have that sort of system within this committee, because that will allow us to track the things that are being done, and when they're being done, what responses are. I totally understand the need for it to be unified, or the hope for it to be unified, but I don't think that should delay this committee achieving things and also checking that they've been done. And from the other side, showing that we've achieved something as a committee. So I'm just concerned that there's a triumph of process over outcome here, and we should just crack on with our own action plan, or whatever we want to call it, tracker, because I think this is possibly the third or fourth meeting we've been waiting for this, and we don't have them that frequently. So I'll just hope we could go ahead with our own tracker, and then at some point absorb that into a system which accommodates everybody else as well. Thank you.
Thank you, Chair. That's a very valid point, Councillor Daly, and I understand, that for quite some time, that the committee felt that they are not having clear vision of their actions, that were made at previous meetings. I'm still suggesting to stick to this model. Reason being is because most of your communication and recommendation will be going to executive. We are also working with executive, with the leader and deputy leader, of having a standing item on their agenda as well, which will get the scrutiny recommendations, and then automatically having the responses, to the recommendations and outcomes made by the scrutiny. That I think that the tracker, I agree with the action plan as well, which we may word it also to be called action plan rather than tracker, but also to have our partners as well clear sight of it, what is outstanding and what for the members as well, and what responses were made and when as well. So, and whether there is some sort of timeline as well. I mean, I'm happy to go along with what the committee would like to have, but I think this would be ideal opportunity for the committee to have the sight about where their recommendations are, at what stage are, and when they expect for it to become, and what responses they receive.
I thank you very much, Jack, for that. I think what I would like to see is called Action Plan Tracker, because I think we can coordinate the two things. I think that we like an action plan where we know where we want to go, we know what we want to look for, and where members are bringing things to the table, but I also want them tracked. So I think let's call this an action plan tracker. How about that? Is everybody happy with that? Any dissent?
Can I come back?
You can.
Yes, as long as we have it.
And the
for
format we
next
want.
meeting.
Yes.
Yeah.
And we do want it the next meeting. Is everybody happy with that? Good. Action plan tracker. Okay.
Noted.
Thank you. We do our own thing on this committee, very much about, we like how we do things. So what we want is for other people to follow us, not we follow them. So just let everybody know that. Okay. So that's really good. Thank you very much. Thank you, Councillor Bailey, for that input. Right now then, we'll go to item 6, which is the progress on implementing the homeless and rough sleeper strategy and action plan. This is on pages 91 to 114. And I'd like to invite Kirsty Larkins, the Service Director of Housing, to present this report. I just want to make sure that would the portfolio like to say something first?
Yeah.
Thank you.
Thank you, Chair. Yes, I'm very pleased that this is coming forward this morning because members will recall that we agreed the strategy in February 25, and I just want to make it clear that since that date of approval, the ground has not, what's the word? Our feet haven't stopped moving to implement it, and the action plan for implementing it has been formulated, but it's been also implemented as well. So there's a lot of work been going on, which Kirsty will tell you about. And I just wanted to draw your attention to the vision section of it, which says that what we really wanted to do was say we wanted to end rough sleeping in the county and homelessness by 2030. That is an incredibly ambitious target, which everybody in this room will recognise. So what we've said is that and then again, it's still ambitious, but we want to make sure that everybody has an opportunity to take somewhere to sleep or to live, because we know that some people will not take that up. You cannot end it completely because some people will say, that's not right for me, I'm not ready for this. So we didn't want to create a target that we can possibly achieve. It is still a very, very tall order to achieve, but we know that housing and a home is the basis for your life. We've agreed that with the Helzos when we met them. And without that, you cannot have a decent life. So I'm very pleased this is coming forward. And you will see from what Kirsty tells you, the hard work that's been going on and is going on now. Thank you.
Thank you very much. Thank you for the introduction. Can I go now, please, to Kirsty for the in-depth knowledge on this?
Thank you, Chair. I will keep it short because I know you've got a very busy agenda today. So just to give you an overview of some of the work, I'm sure you've all read the slides that have been provided. So there's been a redesign of what was the Homeless Reduction Board in Somerset to the Strategic Homelessness Board, to allow us to be more strategically focused. We've become quite operationally focused as a system. Things have become very operational. So we've streamlined that down and moved into a 6-weekly meeting, but we do still have that wider system forum that happens on a 6-monthly basis. Sat underneath the strategy are 4 working groups, and a key part of our working groups are the partners. So each working group is co-chaired by somebody from our partners, but also someone from Somerset Council. We recognise we cannot tackle homelessness and rough sleeping on our own. They are complex issues. There are links with health, mental health services, adult social care, children's social care, schools, police. So all of those links are vital, and we have to take that whole system approach. I won't go through the detail, but you can see each working group has started to make progress. We are hopeful we will have some more accommodation coming on stream in the next kind of 4 months or so, around temporary accommodation for single people, which we desperately need, but also some longer term, more sustainable accommodation as well. Alongside all of the working groups, one of the things we are very keen to weave into everything we do is co-production. Something we recognise as a housing system we haven't always been particularly strong in. So we're also working with Second Step. We funded somebody through them to support us with co-production and how we weave that in through our strategic boards, but also into service delivery and the way we commission services. And that is a key kind of step change for us in the way we deliver. I was hoping we'd be able to bring you a data dashboard today. It's still in development. We are close. And once that's available, I will share that with members of the committee. My hope is that we will be able to publish some of that onto the website as well, so people can self-serve and see progress and see what's happening. But we will definitely have that for the next report in 6 months' time. But we'll have it before then, and I will share with committee members. Open to questions, Chair.
Kirsty, could I just ask before I give that to members, on the rough sleep and action plan progress, there seems to be duplications, but you'll probably know better than that. You've got percentage-wise, the thing that's concerning me is the tenancy sustainment, 35%, and then you've got the improved engagement relationship with charity and voluntary sector, and then there's the other one that's on create client-centered solutions and understanding the barriers. Just wondered why these are all separated. Are they not saying the same thing, or perhaps you can explain that better?
So the creative, sorry, Chair, the creative client-centered solutions is around that co-production and starting to work forward. The creative solutions meetings is part of that, but it's a separate thing. So that's something that we have that's chaired by our partners, Second Step, with other agencies to discuss and look at particular clients that we might be struggling to house. They may have health, they may have drug, mental health issues. So they are separate things.
Thank you. Councillor Trimnell.
Thank you. So this is really good. It's really good work that's being done. It's essential that we get this sorted because it's still so visible on our streets, people rough sleeping, and it causes a lot of difficulty for people. If you give someone a fiver, the next person you see, you feel, do you see what I mean? And so I think it makes people feel really uncomfortable and difficult. You're out there spending money. Why can't I give more people a fiver? It's that kind of thing. But my question is, the work that we are doing is superb and the prevention is essential. But the issue that sometimes or fairly often happens is that people who are homeless are quite transient. And so they don't necessarily stay in the same county where they were identified as becoming homeless. So what are our responsibilities for people who are coming here? Because it's my understanding that our homelessness numbers are quite large, and either that's because of something we're not doing right, or that we're quite a place for people to come. And I wondered if you could talk us through that, please, because that could be the issue. We can prevent homelessness here, but if it's not being done adequately or as well in other council areas, then we may end up being almost a pull factor if we can deal with it so well.
Thank you. So there's kind of two parts to this. So from a homeless perspective, if someone makes a formal homeless application to us, so this could be someone that's living with friends, family, sofa surfing, they may be rough sleeping, that could be it. If they don't have a local connection, we will then refer back to the area that they do have a local connection with. Many of our rough sleepers and vehicle dwellers choose not to make that formal approach to us. We don't have any powers then to be able to refer them back to another authority. Even if we do refer them, that does not mean they have to go. We don't have powers again to physically make that happen. But in Somerset, many of our rough sleepers are entrenched rough sleepers. So some of the people my team are working with, I was working with 20 years ago. So they absolutely, sadly, do have a local connection to Somerset. And sadly, because they've been on the streets that long, they may have periods of being in accommodation and then out again, into prison, out again. And that pattern is repeated. And that's something we have to try and stop and break. And that's why we have to try and look at doing things differently. Because clearly, for some of the people we're working with, that isn't working and it's not sustaining. And that's what's really important. So you're right, prevention is absolutely key. We've got some schemes coming on board, working with Thrive Somerset around their village agents being upskilled to work with people that they think might be at risk of rough sleeping or homelessness, or where people have been housed through our rough sleeping route, but then need that support to integrate into that community. Again, about making that a sustainable solution. So there's lots going on. Hopefully that answers the question.
It does. It's just understanding that picture, that transient picture. I mean, you know, you'll even have that transitory nature between towns within Somerset, you know, so people have the same people in their area, you know, and so it's also then trying to keep on top of that and making sure that we're aware of who people are and where they are. But, you know, it's so important to do work on this and to end homelessness in all its forms.
Just on the transient nature around Somerset, we do have some of our rough sleepers that move around. We've recently, well, as of the 1st of April, brought all of our rough sleeper services back in-house. So we had 2 areas from previous districts that were outsourced and 2 that were in-house. We've now brought that under the same model. And we do have very good communication. So whilst they're area-based teams, because obviously Somerset's a huge county to cover, they do absolutely share that information across, and we try and link. Once we've built that trust and connection with a rough sleeper, we try and keep them with the same person that they're working with, because sometimes that can take months, if not years, to build that trust and that relationship. So it's really important, but the team are very good at sharing information across.
Thank you.
Thank you very much. Councillor Bailey.
Thank you, Chair. Thank you for the report, Kirsty. It's very comprehensive. I just got a couple of questions I'd like to clarify. I think Somerset is about a third in the list of authorities in terms of rough sleeping, so it's really not a very good place to be in the Premier League, really. And the other 2 are London boroughs, is that right? 1 and 2 are London boroughs.
Yes, so I think, yeah.
Okay, so
We're third, which is the 3rd highest number per 100k of population.
Yeah.
So it's different figures that float around rough sleeping, but if you look at our population and the number of rough sleepers, we are 3rd in the country, which is incredibly shocking.
yeah, okay. I just wanted to clarify that. Second question, really, you mentioned the data dashboard. I think you said 6 months before we get it. Was that right or?
No, sorry, I'm hoping. And I will
Okay.
share, but it will formally come back to the committee in 6 months' time.
Thank you. My third point really was about the the need for integration in what we're doing. I think it comes over in your paper that it is there, but this is part of a piece of work which is involved in so many different aspects of social support, right across families and social care and all that sort of stuff. So I just hope, because I think if all those agencies are working together, then we can get a position where we get more power, more bang for our bucks, if you like, to recruit more power in that situation. And reading your report, it seems that is happening, but I think that is critical, rather than having different agencies trying to prove different things or chaps in what's in different directions. So I'd just like to see that area of integration really in the forefront of any future reports. So that was the only comment I was going to make. That's me. Thank you very much.
So, thank you. Councillor Cameron.
How grateful we are, especially in Glastonbury, with key outreach teams. They're doing sterling work. I meet with them regularly on Monday mornings at St John's Church, and so I'd just like to pass on thanks to the community. Couple of questions. I won't pause in between each one, if that's all right. Tell a story first. On Tuesday, I was outside Tor Kebab Shop in Glastonbury. Other kebab shops are available at 11 PM. When I met four residents of our community, young people, low age 20s. All of them informed me that they were rustly sleeping. All of them told me about sofa. All of them were highly fueled with alcohol at the time. A couple of them were smoking spliffs whilst they were talking to me. And one of them then gave me a list of all of the various substances they had taken that day. And so the question is really around, and two of them said that they were van dwellers. So I've got a couple of questions, and that is, do we have sufficient drug and alcohol services capacity across the county? And I know that we're going to be talking about drug and alcohol services later on today. Likewise, mental health services. And then the final question is around our housing needs assessment and the Gypsy Traveller accommodation assessment. And I just wonder, how do van dwellers fit between those two strategies? Because I was unable to find out how we were dealing with that van dweller population. Thank you.
Can I just interject a bit, because I know Councillor Cameron works for the Glastonbury Tourist Board, and we're grateful for that. That you are slightly digressing into other areas, and whilst they're all important, they really are important. I think that we just need to be very careful that some areas are not within this scope. The scope is here, but I think we just need to be very careful today. That's okay. But I do take the points on board. But Christy, do you wish to add anything?
I can give a very quick, short answer if that's helpful, Chair.
Yeah, thank you.
So drug and alcohol services, we would always like more. Sadly, there is always a demand. However, I think working relationships have really improved. So one of the issues we had around our rough sleeper accessing those services was having to go somewhere. We've worked really well together with Estas, who provide our drug and alcohol service, to do much more working together. So their workers are going out with our outreach teams to be able to work then with rough sleepers to reduce that barrier. Mental health, I would say the same. We'd always like more. I think all services would probably say the same as well across the country. That's not a Somerset picture as well. Again, we've got some work in progress with some of our mental health services to look at how we reduce those barriers. But they have been very connected, especially around our vehicle dweller community, where we know there are barriers in accessing health services, to be more proactive in that area and work with Zoe, who's our roadside expert, to again visit. So we're trying to break down those barriers, but if I had a magic wand, absolutely I'd like more of both services. And the housing needs and Gypsy and Traveller and van dwellers, we are lobbying actually MHCLG to have sort of vehicle dwellers recognised, and they don't really fall neatly into any one group. They don't fall in, as you quite rightly said, the Gypsy and Traveller group. They also kind of don't fall neatly into rough sleepers and homelessness. We do count them as rough sleeping if they are living in a vehicle with no cooking, no heating facilities, etc. But we would really like that definition to be broadened out and to include, and I know we're not the only council that's lobbying for that as well.
Thank you, Kirsty. So you've finished. Yeah, yes, thank you so much. Thank you. Kirsty, on page 107, I don't know whether members feel the same thing. It seems to me we've never moved off of no wanting the one-bedded homes. The need for the one-bedded homes. We're in bronze here, showing the total of altogether, but 4,303 in bronze needing one bedrooms. And people are in gold and silver, but it's still 6,493. Can I just ask you, and this is again slightly digressing, I'm doing it, Councillor Cameron really, but I'm doing it because I think what I want to know is how near are we to, we cannot get people off the streets if we haven't got the right accommodation. If they haven't got accommodation and they haven't got somewhere to live, they're not going to get on that housing list for silver, bronze and gold. It's this vicious circle. How near are we to be able to be getting one-bedded properties for people? Because we don't want to put them in a two-bed, that's understandable. But it seems to be, unless we do, it's a chicken and egg here, unless we get one thing in one place, we're not going to get them off the streets because they've got no accommodation, they've got nowhere to live and they cannot register. Thank you.
So just to clarify, if someone is rough sleeping, they can still register on the housing register, and we absolutely encourage them to do that. So there isn't a barrier around having an address. So just to sort of clarify, that doesn't stop people. By far, as you can see, over half our register require one-bedroom accommodation, and that's been the case for quite some period of time. So we are working with our partners and with developers. So when new sites are coming on board for one-bedroom accommodation to be built, but there is a balance as well. Nobody wants a whole estate that is just one-bedroom flats because it doesn't create that sustainable community. There's also sadly a financial balance as well. One-bedroom accommodation is more expensive to build. It's more cost-effective for people to do 2- and 3-bedroom properties rather than one bed. So we absolutely do fight for that. We absolutely do work really hard with our partners to bring that forward. But sadly, you'll see we've just got over 13,000 people on the register, and last year I think it was 1,700 lets. So demand really outweighs, what the supply is at the moment. We have got new funding programmes coming in. So there's the Home England 10-year funding programme. Our partners are bidding for funds to bring on 100% affordable housing schemes, and we are supporting them with that. We won't know until kind of October whether they've been successful. So there's a real role for us as a council to play in making sure that we're working with partners to get the best for Somerset.
Thank you, Kirsty. I found this report very, very good, very, very comprehensive, very enlightening. And I would like to say to members, if you feel that we want to put something together for the executive as a recommendation, that we support you on this task of finding one-bedroom homes. Perhaps this council, whilst it may not be sustainable, it may not be good for families or whatever, we need to stop this happening. We need to find one-bedded homes. We just need to do more towards it. And if there's something you think we could do, we would gladly do that. I think it's something we should do. So I'm going to put this out to members now. So Councillor Hobbs.
This is digressing in terms of finding one-bedroom homes. You may shoot me down. But I see many empty flats with access from the high street, even in Wales High Street, which are totally empty. Is there any way we can fund getting those refurbished so people can rent those? Because you walk down in High Street, you see all the upper floors empty, and not all of those are accessed through the shop. You see some with side accesses where they could be refurbished. Is that digressing too much?
Well, we do digress, but many of these are not owned by the council, so you have to remember that. That's we have a lot of property owners, but can I go to the portfolio holder and then come back to everyone else on the list? Thank you.
Yes, I just wanted to say, in my former life, I was a investment lawyer. I bought a lot of shops for my clients. That was one of the things they invested a lot. They didn't want people living upstairs because they leave the water in the bath and it overflows and it causes problems. You have to have hopefully responsible tenants living upstairs. But you're absolutely right. There are lots of shops which have got flats above and they are empty. And I think it's expensive to bring them back into use because of the modern requirements which don't apply to some of the old properties or didn't apply. So I think that's a possibility, but we are looking at everything that's available. I mean, people don't like houses in multiple occupation, but a room in a house, a shared house like that, is better, probably, you and I would think, than sleeping on the street. The other thing is you've got to understand that some of these people, they don't trust anybody, don't really know how to manage a tenancy either. And therefore, they're not the landlord's first choice if it's a private landlord. They're going to say, this person's going to be difficult for me. I'd rather have somebody with it. We've got a dearth of properties in Somerset because of Hinckley, because of the other things that are going on. All the best places are already occupied by people working there who pay regularly. So one of the things we're suffering from is that. And I don't think we're going to persuade the housing people to build lots and lots and lots of one-bedroom flats. But we can convert properties that we've got. We are looking at the sites we've got in Somerset. We are looking at getting in Homes England money and working with our registered providers to revitalise some of those smaller places that you might get 6 dwellings, something like that. You don't want 250 in one place. That would be the wrong thing to do. So we are looking at all the options, but I think people need to understand it isn't as simply saying, you're on the streets, here's a place, why don't you go there? It's just not going to do that. You need a lot more work than that to get somebody into accommodation.
Can I just say we do have an empty homes officer within the service, and they will work with owners of properties to bring them back into use. So we've got a great scheme where we use a charity that's been set up that will support the landlord in bringing the property to use and then lease the property from the landlord and manage the tenant, etc. So if you are aware of any empty properties, please ping me the addresses and I will pass those on and make that connection for you with our empty homes officer. But Sarah's quite right in what she said many times. They are not interested. They don't want a tenant in that property. And, you know, sometimes people we're working with aren't the easiest tenants, not in all cases. But, you know, it can be more challenging then. But absolutely let me know, because we never miss an opportunity.
Kirsty, your email is going to be bursting. I know. So, okay, can I go to Councillor Bailey, please?
Yeah, thank you, Chair. Just a final question from me, really, which is that I totally applaud, and I think we all would, the aim of rough sleeping being zero by 2030. What I couldn't see in the report was the steps, the milestones in the years between those. And it'd be good to have that as the aims that would take you from A to B, or A to Z in this case. And then we can see how things are going, because I fully appreciate that there are some things are negative here, but there are some people who are not low-hanging fruit in this area and have been on the streets and you see them and you go into a village or a town, they've been there for donkey's years. So it is quite difficult. And I think that eventual 2 or 3% will be quite difficult to get there. Having said that, I think it's great to have that aim. I'd just love to know, or like to know, the steps annually to get there, please.
We're very happy to share that with the committee. We do have another kind of more detailed report that kind of sits under these with those steps that we're looking in and which groups we're going to kind of target, because you're right, some will be easier, still challenging, but easier to work with and accommodate compared to some that we've got that are very entrenched. They don't, as Sarah said, trust services, any services, so those will take longer. But yeah, happy to share that outside of the committee with the committee.
Thank you.
Can I have Councillor Strong, please?
Thank you, Chair. Thank you, Kirsty, for the report. It's really good, and it's really good to see so much work has gone into it. So I've just got a little question or point around SWEP. So you're absolutely right. When SWEP is called, that's an opportunity that you don't always get, where you can work with that client and you can really get in there and you can talk to them, do the assessment and support them. My only worry is, helpfully, sometimes SWEP is called over the Christmas period when there aren't that many staff about. So if it goes to out of hours, and then, you know, SWEP can sometimes only be a couple of 2-3 days. So I just wondered if there was a staffing plan for the Christmas period to make sure that these people don't get missed.
Thank you. So just for those that don't know, SWEP's the Severe Weather Emergency Provision. Sorry, I probably didn't put that in the report, so apologies. Too many acronyms, I know. So we do tend to not end SWEP on a bank holiday or a weekend. So we don't have that issue, because what we don't want is people going out before we've had that ideal opportunity to engage with them, because you're quite right. Sometimes that's our only chance of actually making that link and engaging. We're also reviewing how we provide SWEP. So at the moment, it tends to be bed and breakfast accommodation. We want actually to bring people into accommodation where there's some support and we can take a more holistic approach rather than just the roof over their head. So we are looking at that. And as I say, we don't let people out over the bank holidays so that we do get that chance to connect.
Thank you, Kirsty. Does anyone else wish to say anything before I? Oh, sorry, councillor, also another portfolio. We're very lucky today. That portfolio for health, councillor Graham-Oates.
Thank you, Chair, and for your indulgence. It's merely a question. That was, I wondered what the status was of these empty flats of those shops, in the sense of, are they liable to council tax? Or is there any, I know there are grants that can help people to refurbish them, but is there also that's the carrot, there's also a stick to say that you choose, when we've got a homeless crisis, to leave this property empty? Is there any sort of financial incentive to make them do this, as in council tax, as we do perhaps with second homes?
There is an incentive. I can't remember what percentage it is, but rather than it being a very cheap council tax, it then turns into a very expensive council tax. I think there is some leeway, because obviously if somebody passes away and you need to sell the property, etc. But I can ask a revenues expert and we can come back to the committee with that.
Thank you very much. Thank you. That's a very good point raised. Thank you, Councillor Oates. Councillor Palmer.
Thank you, Chair. I think just regarding the old shops that that's been mentioned as well, obviously it will take a lot of work going into making them fit to house people, but it's just, with my 3 years of sitting on the Devon and Somerset Fire Authority, it's just making sure that these buildings are sufficient with fire alarms, fire escapes, because obviously they're on top floors. It's making sure that people are able to get out. It's just, you see things on people rush sleepers and then there's a fire downstairs. Fire exits are blocked, there's no smoke alarm. It's just making sure that if we do this, that the fire provision is there. Thank you.
And I just reassure that we work really closely with our colleagues in housing standards to make sure that is the case. It's a really important point.
Well, I'd like to thank you, Kirsty, very, very much for this report. We're noting the contents of the report. We have to consider and comment on the progress of the Somerset Homeless and Rough Sleeper Strategy Action Plan. We're here today to agree the next update on the action plan progress will be presented to scrutiny in April 2027. Gosh.
The proposals to do a written report, 6 months in between, so there's an update for members.
I think, Kirsty, this is a very, very important, and I would like to ask if we could give you back.
In 6 months.
6 months.
Chair.
No, I want to see you again. I think we'd like to see, I think it's important that we actually do comparisons, Kirsty, that we compare how things are now, how they've moved on. But I also would like to say whether members consider that we should be putting a recommendation to the executive to say that you would need more support for the 1-bedroom homes. Maybe there's something really strong that we could support this. Rough sleeping, you can only do it if you've got the properties and vice versa. I wondered what the committee felt about that, please. Councillor Trimmer.
Can I just clarify, are we talking about building 1-bedroom homes or finding 1-bedroom homes or finding HMOs, for example, where people have a room each within a house? So is it a sort of a mix of all of those ways? Because I just wonder, we don't have a great deal of money to buy more property. That's the problem. So, because I really support it, don't get me wrong, I massively support it, but I just wonder how we can achieve it.
Perhaps I should have said finding, maybe that would have been better. Kirsty, could you just back on that one? I've got you, Tom, thank you.
I think whilst I'm really grateful for the support from members and it's very clear, I think the ability to kind of is quite is quite difficult. I think the best way members can do it, for those of you that are on planning committees when affordable housing comes forward, to support those applications for affordable housing, the more that happens. Other part of this is also working with supported housing. So for some of our groups, actually, one bed self-contained property isn't the solution. They need a more structured, supported approach initially. So, and I think some of this work we picked up as part of the task and finish group that obviously several members were involved in as well.
Okay, thank you, Kirsty, thank you.
Chair.
Oh, sorry.
Quickly, I just wanted to make it clear to those who are listening and in the room that everybody on the home finder register are not homeless. That doesn't mean they're all homeless. It means they need a different home or they haven't got a home. So you can't assume that all those 13,000 households are all on the streets. They are not, but they do have a long wait to get a bigger, more suitable home. And obviously the one bedroom ones are the ones we've got the biggest numbers, as you've rightly said, but they won't all go into council accommodation. A lot of people will find their own.
Just think it's what Kirsty's report has done today has actually shown us exactly where we have that weakness. And I think that's why it's very important. Councillor Bailey.
Thank you, Chair. I just wanted to, support your comment about one bedrooms, but also just to highlight what Kirsty's just said, that there's a task and finish group involved with this meeting this afternoon. And one of the key things that's come out, from my impression, is the need for one bedroom accommodation. So it will be coming out of the process as well.
Of course, yeah.
The challenge is not just to state that, but actually to think how we actually meet that need. And that's the challenge. And that's why we've got the situation that we have today. But certainly that's part of the process, and it'll come in the report in July.
I think I was just trying to, I like to reach for the sky, me, and, Councillor Powell.
So there you go. Sorry. I think it's very good to go to the executive, but as we said, we are the third. Point to the Secretary of State, because with the third worst in the country, I think it needs to be escalated a little bit further than the executive to see if the government can do anything about it. I'm just putting the idea out there. I mean, people might disagree, but it's just an idea.
I have to say that the MHCLG have recognised that we need more assistance, and we have been getting funding. So those of us that have higher numbers, and we've been very successful in doing that, and we've just supported our partners in also applying for funding, and I am hopeful that some of those bids will be successful. So absolutely, the MHCLG does recognise as an issue, and they have reflected that in their funding. Obviously, I'd always like more funding like services, but realistically, they have recognised it and responded to that.
Thank you. I know we have a task and finish group, and the task and finish group will obviously make some recommendations, but it still has to come back to us. And what I was trying to say was I was just trying to cut the corner, really. But Councillor Hobbs.
Thank you. Thanks for that, Kirsty. It'd be nice to see what that extra funding is for, what that actually equates to in terms of number of rooms.
Okay, well, listen, I think we've done, so we won't do the recommendation as such, but I think we'll really keep that on the back burner if that's okay, because I still want to support you in the best way I can. And you are doing a good job, and we really appreciate the work that's been done on this, Kirsty. I do want to see you in 6 months, because I think having you here, being able to answer the questions and being able to explain to us the wheres and wherefore of things that are right and wrong, it does really help. So thank you very, very much for this.
Thank you, Chair.
Thank you. Thank you. And it's very, very good. Thank you very much, committee, for your involvement. The next item we have is item 7. This is the draft adults and housing workforce strategy. This is on pages 29 to 86. And I'm going to invite Emily Fulbrook, the Service Director of Adults Health and Operations, to present the report. I'm inviting members to obviously, I'll do this summing up. There are some recommendations there. I'll go into the recommendations after, but over to you, Emily.
Lovely, thank you. Thank you, Chair. So this is the draft adults and housing workforce strategy. So you've got the paper and there's a slide deck. I'm not intending to go through all of that today, but just to pull out some of the key highlights of both the report and the slide deck as well. So the purpose of the report is to set out the draft adults and housing workforce strategy for 2029. And it has been informed by quite a significant staff engagement as well, and also looking at our workforce data. The strategy also underpins the theme 3 of the adult social care strategy that I presented at last month's Scrutiny committee, which theme 3, just as a reminder, is surrounding a supported, skilled and flexible workforce. And it also aligns with the council plan as well. The report and the presentation just takes us through some learning from our previous workforce strategy. This isn't the first one we've had. We had one between 2024 and 2026. Just wanted to pull out some key areas of what worked well and areas for improvement that hopefully we've covered in the future strategy. So what worked well? So we had a clear evidence-led workforce strategy with strong governance through our Adult Social Care Workforce Board. We progressed with recruitment and retention, including a successful international recruitment, and we reduced reliance on our agency staff. We had continued investment into our workforce development through our ASYE, which is our assessed and supported year in practice for our newly qualified social workers. We had a successful return to practice as well for those individuals that were re-registering in terms of their qualification as either a social worker or an occupational therapist. And we had some various leadership development that took place. We increased our focus on staff wellbeing and supervision, and we aligned with our system-wide priorities, including the Sunset ICS and people plan. Some of the key areas, though, for improvement are surrounding impact and measures were not always clear and consistently embedded. Variation in staff experience between teams. Digital enablers were referenced but not fully realised. And ongoing recruitment, whilst we have had some successful recruitment, we know that there are some ongoing recruitment challenges in high pressure roles as well. In terms of our workforce profile, so the total workforce across the adult social care operations, commissioning and housing is a total of 577 staff. Our workforce reduced by around about 5% in the last 12 months, and this was following the restructure that took place last year. We do have an ageing workforce with several services having high proportions of staff aged 50 plus, creating concerns surrounding succession planning and risks over the next 5 to 15 years. Adult social care itself has a higher level of reported disability than the council average, a predominantly female workforce, particularly within our frontline services, and a greater ethnic diversity in across our operational teams compared to the wider council. And some of this has been supported partly through our international recruitment. The risks informed our priorities and actions, and in the actions within the new strategy, and also the equality impact assessment. As part of our staff engagement, what staff told us was that they wanted to, for wellbeing to be embedded in everyday practice, including consistent wellbeing check-ins, flexible working and realistic workloads. More equitable and inclusive workplaces with fair recruitment, development opportunities and inclusive leadership. Support to adapt to new ways of working, including digital change and service transformation. Stronger connection, belonging and team identity, especially in hybrid and more of that sort of hybrid working, remote working. Improved onboarding, so of individuals' induction and career progression pathways. So in terms of the strategy and the priorities for 26 to 29, there are 3 core aims with 4 priority areas. So one of the overarching objectives is surrounding our staff wellbeing, and we feel that is central to our service delivery, and to build a diverse and inclusive and equitable work development in terms of our leadership. So priority 2 is about reset and refocus. So to support staff to embrace change, innovation and continuous learning, strengthen our culture, belonging and collaboration across teams and services. In terms of priority 3 is surrounding attract and retain. So improve recruitment, onboarding and induction, invest in our career progression, specialist skills and succession planning, and continue to reduce the reliance on agency staff and plan for long-term workforce sustainability. The 4th priority is surrounding improve and thrive. So embed trauma-informed practice and learning and recognition, develop a consistent and equitable workforce development offer, and harness our digital and AI tools to reduce administrative burden and improve productivity and quality. So each priority is supported with clear actions and outcomes and measures. We also have identified leadership champions for each of those draft priority areas as well. So how will we ensure in terms of governance, assurance and equality? So delivery will be overseen by the Adults and Housing Workforce Board with regular monitoring and annual review. A full equality impact assessment has been completed and is integral to the strategy. The strategy supports our statutory duties under the Care Act 2014 and will also inform CQC local authority insurance requirements. There's no immediate additional financial commitments. Delivery is within existing resources and workforce budgets. So that's an overview of our adults and housing workforce strategy. You've got the information there, and also in terms of a little bit more detail surrounding each of the priority areas. This is draft, so I would really welcome members' feedback to the draft proposal.
Thank you, Emily. I'm going to get in there first, if I may. Thank you for the slide deck as well. A couple of points I would like to ask the committee what they thought really about this. On page 55, the people strategies are a commitment to making this happen. And we'll do this by being brilliant at the basics. I would like to take the word brilliant out. I think it should be, we were being smart, being excellent, or being better. But I think brilliant's an awful lot of pressure. You know, we'd all like to be brilliant, but you know, I think we need to be, so I didn't know what the members thought about that. I think the brilliant goes right the way through. You've got it on the following page as well. They used brilliant. The other thing I'd like to say is the staff told us. There are 6 slide decks here about what the staff told us. It's certainly come to understanding staff capacity. I think that's absolutely essential. Maybe that should be at the top because I think I'm a little bit concerned about the flexible working. Whilst I understand about flexible working, I think we need to be, that looks a little bit, and I need that to be defined a little better. If you could. The other thing is we need to know there are enough, you've got honesty. I don't know why we need honesty in there because I believe all staff are honest. I don't think we need honesty, my personal opinion. I think that the joined up working, but enough staff to do the job, the capacity, I think is very, very important. I tell you, I wrote notes all over this. But I'm just a bit concerned about, and training. I think training should be perhaps the first bit. Staff told us, I know you've got them separated, but I think training, every member of staff needs to be properly trained. Without them being properly trained, they can't do the job, and we can't expect them to do the job. So I'd like to see that with a little bit more measure to it, really. I'll probably come back in a minute, but that was my starter for 10. Anybody else have any comments on that, please? So who was Councillor Cameron, and then Councillor Trimmer, and then Councillor Bailey.
Thank you, Chair. And in the direction you've given us earlier, I'll try and reach for the sky without being brilliant. I did thank you very much for the paper. Really, really good. The only question I have is where do we see continuous improvement? I didn't see it mentioned anywhere. And given that we've got such a large transformation requirement as part of the council's aspirations. How are we providing that Lean Sigma central ethos that we would expect all of our staff to have going forwards? Because if we're not giving them the skill set, it's going to be jolly difficult for us to be able to deliver on the transformation. Thank you.
Yeah, thank you. I'll take that on board. It really should come into priority in terms of that improve and thrive. So we'll make sure that's highlighted even further.
Thank you very much. Councillor Bailey.
Thank you, Chair. Thank you, Emily, for the report. Just in terms of consistency, I'm slightly confused because I understood earlier on in the document there were 3 priorities: reset and reform, refocus, sorry, I read my own writing, attract and retain, second, and improve and thrive. When we look at later on in the report, there were 4 priorities. Sort of consistency, could you just clarify that? I've got other questions, but.
Sure. So there are 3 core themes. So reset and refocus, attract and retain, and improve and thrive. But there are 4 priority areas. So there's those overarching priorities. That's priority 1, the overarching objectives. Priority 2 is reset and refocus. Priority 3 is attract and retain, and priority 4 is improve and thrive.
Okay, thank you. Well, the next question is that it mentioned in the research that you've done that lack of experience, I think, was the variation in experience was the terms you used. And I thought that was really down to the development aspect. It may be the question that was asked on training earlier on, and I just thought that perhaps would have a higher priority or be more exposed to the unpracticed eye reading your paper, if you like.
And it is within the priority 3, so our attract and retain. But I absolutely take on board in terms of that continuous professional development needs to be much more clearer, particularly within the priorities. I think it's more really for me in terms of the action, the outcome, and then the measure. So how we're going to really be able to measure the success and the impact that has not just on our workforce, but more importantly to the residents and communities of Somerset.
Thank you. Yeah, I particularly have a concern because of the downsizing of the workforce that's been going on over the last 3 years, that experience is moving on, and how we actually in any organisation pass that experience on and don't go around the wheel once again. And my final question really is about the where this would fit into the health outcome tracker in terms of what we'd be looking at in the future to sort of just scrutiny and overseeing, if you like. What you can help me on that, Emily, please.
Yeah, and what we intend to do and what we have done in our previous strategy is to do a review. We've also had our audit also look at our strategy, looking at the outcomes that we're looking to achieve and then the measures. My intention would be to bring you back a midway report, actually what's been the impact. So particularly things like continuous professional development, actually what's the figures looking like, what's the impact that's actually having for people, looking at our supervision rates, what's happening, what's taking place, looking at our retention figures, our recruitment, so how well is this strategy actually working, because there's some big challenges here. We know that there is a challenge, not just for Somerset, but up and down the country, and not just in social work or occupational therapy, but also within our housing colleagues in terms of being able to recruit and retain individuals. So I'd like to be able to bring back to scrutiny in terms of that. This is what we've done, this is what we've achieved, or this is where we're struggling, and what can we do as a council to support some of that as well.
That's good answer. It's going, sorry, switched on, thank you. It's going back to the outcome tracker, and if that is going to be every meeting, I've got 2 questions really, I suppose. You'll then be reporting every meeting, and my next question is that too onerous and will take time away from actually getting on with the job, in which case the volume, the outcome tracker is going to have not be reported every meeting, if you like, from your perspective.
No, we wouldn't intend to bring this back every month at all. I don't think that would be beneficial for anyone. I think we can put in be that 6 monthly, be that annually in terms, I mean, this is a strategy to last us until 2029. So this isn't a year strategy. Monthly, certainly not. We would meet on a monthly basis, the adults and housing workforce. So we would monitor and track through, pick up key themes, but certainly I wouldn't be expecting to report back to yourselves on a monthly basis. We can definitely work through in terms of how the frequency surrounding that, but I would minimally annually on an annual basis, I would be suggesting.
Thank you.
I think we need to explain that the tracker will not be at every meeting, so I'm going to hand you over to Jack now to just give you the more professional.
Yeah, thank you, Chair. Sorry, Councillor Bailey, just to explain, this would be on a work program for every meeting or every other meeting. Outcome tracker is a recommendation or decision that the committee made that will be in the outcome tracker, outlining how often this item will.
Thank you, Jack. Councillor Tremlett.
Thank you, Chair. So I have a few points and I've written them down in my tiny writing, my tiny book. I couldn't find my bigger ones, so apologies if I'm trying to track through to see what I wrote. But I had a few notes to make. First one is my sign off on the strategy wasn't recorded, and I just want it for the meeting that I did sign off on the 6th. So that people aren't looking there, good grief, she's tardy. I was a bit tardy, I guess, but I did sign it off. Now, there's some really useful data in this report, but I did note that on page 40, reference is made to the new Somerset Western Taunton district. Now, I recognise the size of our county does mean that we need to refer to certain areas of it, and I don't have a problem with the district being used to identify those areas. But I just wondered, had I missed something in terms of the new? Is this sort of a formalised thing that we're doing now? So hopefully that's just a quick answer. Now, the assessment. I've got two questions on that. The first one being, and this is deja vu because I think I asked this, I think it might be in the housing workforce strategy. And I remember sitting almost here in the room asking the same thing. Is this the impact on residents or is it the impact on the staff? Right. And then finally, I noted that there are concerns over the ageing workforce. And it's mentioned staff may be continuing to work with health conditions that will continue to need additional support. Now, I support and I commend the efforts to employ younger people. I think apprenticeship schemes, everything that we do. I'm a parent of young adults myself. I want them to have opportunities within the workforce. However, because I'm a parent of younger children, I'm also part of the ageing workforce now. And I want to speak up for the ageing workforce because what I don't want, when we've got people, there are people of my age. I had my children fairly young. I was 25 when I started my family. There are people who are 10 years behind me who will be looking to go back into the workforce now. And I just want to make sure that in no way will there be a kind of, oh, she's really good or he's really good, but quite old. And we're worried that it would cost us because the younger workforce, we know that there is an explosion of mental health problems within the younger people or the younger generations. We know that younger women may go off and have families. And so, it's not just an older workforce problem. And that was my only little thing just to speak up for us oldies. Thank you.
Oldies, as if.
Oh, thank you, Lucy. Absolutely not. And there's no way that I'm saying we don't want people working for us that are over a certain age. That's not the intention of this. We do have to be realistic, though, that we have got some of our teams, that the whole of the team age, if they were all to leave, and we've got a much younger, it's the skill set that we lose, the knowledge that we lose. So what we need to be able to is that really good succession planning, and which we have done successfully well with the previous strategy. And we have got a variety of workforce across the adults, operation commissioning and housing workforce. So I'm all for that. So this isn't about discriminating or restricting in terms of from an age point of view at all. Just to be clear, the equality impact assessment is for our workforce, and the strategy that's then informed the strategy. So there's a number of things that the strategy then looks to address that has been identified as part of the equality impact assessment. I can't answer your questions surrounding the new West Somerset. It's not my form, so, but I will take that back and get some answers.
I just, so the only reason I asked was because it was marked as having a negative outcome for age, I think is the protected group. And that was why I was just asking if it's a negative outcome, then obviously that might be reflected that older people might be less likely to get jobs. You're absolutely right. I have no doubt in my mind that if we end up with a load of people who all retire within 5 years, we lose all that experience and knowledge. So I don't have a problem with it as long as I know that that cross in that negative outcome box doesn't relate to you're going to struggle if you're a bit older to get a job with us. And I didn't think that it would be, but I just wanted to get that aired and make it clear. So thank you.
It's very difficult, Lucy. It's trivial to think of you as getting older. I think that's where the problem lies. Okay, Councillor Govia.
Yeah, thanks, Chairman. Andrew Govia, Wellington. Thank you for the report, Emily. I think it's really helpful. I know Councillor Bruce, who I think she initially asked for something to come along these lines because of her concern about, the situation we're at. And I just wondered if you could sort of have members of staff who are looking after the most vulnerable people in society, and I just wondered how they regard the way that as a council we're all aware we've been through a huge upheaval over the last few years, very sadly very much driven by financial situation. And I just wonder how that is now. Is it now the hope that as we hopefully settle down and the financial situation stabilises, let's put it that way, that again, Somerset Council will be looked to be an employee of choice, where people will choose, because we know also that while they're looking after vulnerable people, that the salaries sometimes people get paid are not huge, and that makes it difficult to recruit staff and retain them, particularly when there might be other jobs in other sectors which maybe perhaps less require less impersonal input and may still be financially rewarding. I just wondered if that was sort of a factor, and whether now if we are starting to looking towards 2029 whether hopefully we can get some sort of stability in the workforce and get people to take it as a vocational career to come into the service. Thank you, Chair.
Thank you. I'm going to speak on behalf of Kirsty and Paul Coles as well. So the 3 service directors that we have across Adults, Operations, Commissioning and Housing. We're extremely proud of our staff that we have with us. They do a brilliant job day in, day out. All of our teams are working under some quite difficult circumstances at the moment as well. We have vacancies across the workforce. But day in, day out, people are striving to do the absolute best for the residents and communities of Somerset. It is quite clear in some of the staff engagement sessions that we did, pay does come into being a factor, vacancy does come into being a factor. We have also done quite a lot of work with new starters coming into Somerset. We have change the way in which we're highlighting those new people that are coming in with us. We're doing blogs, we're doing podcasts, we're really shouting about the brilliant work that's happening in Somerset. We had a staff event this week where we were talking about our inspiring innovation and the opportunities that we've got within adult social care and housing. And it was really infectious, the passion that came out from our workforce in terms of the opportunities and the new ways of working really shone through. So I think I'm not going to underestimate the challenges that we've got ahead of us and the impact that some of the restructuring has had in more areas than I would say in others. But we've got a very committed workforce that are very passionate in terms of the things that they are doing and the opportunities that come forward. But they've also been very honest with us as well in terms of saying it's particularly some of the things that you've highlighted. So yeah.
Could I just briefly come back and say,
Certainly.
thank you for that, Emily. I think that's incredibly important. Certain factors are beyond our control. The external financial situation is, it is something that we have very little control over. But I think, what is reassuring in your answer is that we are doing all we can to, work with staff to ensure that they feel that they are valued as you quite rightly said, and that then works on to the fact there is a career within the structure which actually they can follow and actually can be a worthwhile contribution to the work in Somerset. So that's been really helpful. So thank you.
And can I just remind members as well that on page 33 it actually says that the adults and housing's workforce strategy has a positive health and wellbeing implications by placing a strong emphasis on staff wellbeing, resilience and support, recognising that a healthy, supported workforce is essential to delivering high quality care and support. While this is the strategy, can we remind the housing adults and housing workforce strategy, this goes along for all of our staff that work in our council, every different department. It's very essential that all of our staff are well looked after. So it says the workforce strategy contributes to a wider social value outcomes, including improved wellbeing, stronger communities, sustainable local services. And it has to come from within for us to be able to get out there and get that message out. So I think that's a very important fact. The one thing I wanted to ask, Emily, if I may, the 7 pages on the slide deck about our staff has told us how brilliant that your staff were able to speak up. Very, very rare that happens. I just wondered, please forgive me, this is not going to sound right, but I almost feel like, is there any way this could be consolidated rather than 7 pages? Rather than, I feel like it should be given, better pay. Many people will say, well, if they didn't like the pay, why did they take the job? That goes along with everyone. But I just wondered whether we could consolidate these, examples of staff about making the workplace more equitable. Everything's different, adapting to new ways of working. But I just wondered whether, I want to make it, may I say this, and please forgive me if you think I'm wrong, whether we can give this professional way of looking at this, because it is important, really is important, the factors that they brought up. And I don't want it to be, it's all lovely and coloured, please forgive me, it is coloured and it's good, but I actually wonder whether we could make that a little bit more professional. Would that be possible, or am I totally wrong? Sorry.
No, you're not wrong. I think this is highlighting the various questions that we had asked the workforce. We've pulled all of the themes out, so they're now into more overarching themes. This has just given a bit of an information in terms of some of the engagement and the questions that we asked our workforce. And you're quite right, our workforce is very open and honest, and they feel comfortable with being able to do that as well. And I think that's a real strength of the adults and housing service.
I just felt the slide deck is a very, I think slide decks give you that information straight on, but I think there's a way that we can consolidate, not losing the different areas. I don't mean to not lose the different points, not at all, but I think we need to make that very professional. Does anybody else agree with that, or do they not? Please speak up, don't be afraid. That's the truth, General.
I think I understand where you're coming from on it. In that often, I go to conferences and things, we do a thing where you all put in a word and then it all gets collated into a thing. And visually, when you're looking at that in a room full of people, that makes sense. But maybe listing some of the most recognised or the most repeated outcomes and things like that might be useful. So I'm halfway there. I think I understand where you're coming from. It's just presenting it in a document form rather than a slide presentation form.
Yeah, for sure. And you're absolutely right. This is generated through what we call a Mentimeter. So, and the reason why some words are larger than others is because the more people that say it, then it comes out. I absolutely take that on board. And when we do future presentations, we'll look in terms of how we present that.
Because this is a thank you, Councillor John. Because this is in draft, I would just like to change this for do this.
Just to be clear, so those won't be in the strategy.
Okay.
So no, that won't be in the strategy.
excuse me.
That was in terms of just the purpose for today, to show in terms of the level of engagement that we have done across the adults and housing work won't be in.
Oh, well, I apologise. I do apologise. That makes much more sense now, so leave it as it is. And I would like you to please give the staff our appreciation to their honesty, and how they felt they could speak up and say what they felt. And I think that honesty is very important for us to have a good staffing relationship with our officers and everyone else. So thank you very much. Thank you so much for that. I think we're all, nobody else needs to say anything. Okay, now then, the recommendations are that the adults and scrutiny endorse the approach with the changes that we've asked for. That's okay. The committee is asked to provide feedback. We've done that to strengthen the strategy for the approval. And I think we've given those extra comments. Does everybody agree with the comments that were made today? Is everybody happy with those comments?
Yeah.
So taking those comments on board, we all agree to endorse this strategy.
Absolutely.
Everybody, could you just show your hands, please? Everybody happy? Thank you very much. Thank you. Thank you very much. And obviously with those changes, it would be nice for us to see the final one. That would be okay. All right. Thank you very much. So now we come to a very important. You're going to have a comfort break for and it's very hard. I said 15 minutes. She said no, it has to be 10. So 10 minutes, please. Comfort break. Members, we're now going into item 8. Thank you for those online. Apologies for the delay. I'm advising members that associated with this report is supplement 1, Somerset Stroke Services reconfiguration, implementation phase summary of the communications approach. I'm inviting Alison Rosewell, Director of Localities and Strategic Commissioning, NHS, to introduce the report and introduce her colleagues. Now, I have already introduced the colleagues, and I want to say thank you very much to Anthony Heron, Gary, and Dr. Robert Whiting. Thank you so much. And I'd also like to thank those eminent people online, and thank you for being here today. So there are recommendations with this, which I will talk about in a moment, but I would like to now hand over to Alison Rosewell, please.
Thank you, Chair. And thank you for having us here today to give you an update on the reconfiguration of stroke services in Somerset, following the formal decision that was taken in January 2024 by NHS Somerset Integrated Care Board. We wanted to update you that we are now at the point where the new and improved stroke services are opening on a phased basis, starting at Dorset County Hospital in the first week of June. Service will then go fully live in the first week of September, when Musgrove Park Hospital opens, and from this time onwards, patients with a suspected stroke from the Yeovil area will be taken to Musgrove Park Hospital in Taunton or Dorset County Hospital in Dorchester, where they will receive the expert care they need. The new model for stroke services includes hyperacute stroke units, also known as HASUs, at Musgrove Park Hospital and Dorset County Hospital, acute stroke units, what we call ASUs, at Musgrove Park Hospital and Yeovil District Hospital, transient ischemic attack or TIA services, which will be 7 days a week at Musgrove and 5 days a week at Yeovil. Under the reconfigured model, people in Somerset who are suspected of having a stroke will be taken to the nearest HASU, where they will receive specialist care during the critical first 72 hours at either Musgrove or Dorset County Hospital. After approximately 72 hours, patients who require ongoing inpatient care will be transferred to an ASU. So for people living closer to Yeovil, they will be transferred to Yeovil Hospital to continue their recovery. Significant work is underway to ensure that the reconfigured stroke service can be introduced safely and effectively. The estates work will be completed, the workforce in place, and the clinical pathways finalised. We have also included with the paper a summary of the communications approach. We want to reiterate that members of the public do not need to do anything different when the new service goes live. They still need to call 999 if they suspect they are having a stroke, and the emergency services will take them to the right place. We are requesting that members are asked to note the update on the reconfiguration of stroke services and indicate whether the committee would like to receive further updates as the service is implemented and develops. I will pass over to Gary now, who wants to just respond to the query earlier, but also just to say that we will then, after that, respond to any questions that members may have. Gary, thank you.
Thank you, Alison. I'm Gary Risdale. I'm Director of Operational Transformation in the Trust, and I've been leading the implementation of a reconfiguration since last spring. Just in response to the concern around the future of the acute stroke unit at Yeovil that was raised at the start of the meeting, both the ICB and the Trust gave commitments that part of this reconfiguration would be investments in the rehabilitation offer that is made in the acute stroke unit in Yeovil. That was initially planned to be a refurbishment and building work on Ward 8B, which is the current stroke unit. Unfortunately, due to the new Building Safety Regulations Act, we're having to do a wider fire strategy work within Yeovil Hospital, which could potentially have delayed that building work. Following a suggestion from one of the stroke team within Yeovil, we are instead looking at moving the stroke ward up to level 9. For those people that have got a very long memory of Yeovil Hospital, I've been assured that when the hospital was first built, Ward 9 was originally a psychiatric unit, and it was a psychiatric unit until the opening of Summerlands in the 80s. That means that within the configuration of Ward 9, there is a large area that was previously a day room, and also it is a daily living rehabilitation flat, both of which are currently used for staff offices and restroom facilities. The suggestion that we received that we're now going to proceed with is actually reinstating the activities of daily living flat, which means that there will be a rehabilitation kitchen, a rehabilitation kind of day room kind of area that we're going to put comfy chairs in, as well as the bathroom. And what was the previous day room is going to be converted into the gym. This means that we're able to do a great deal of rehabilitation offer. It actually gives us more space than we were anticipating doing the building work on level 8. So this is a really good suggestion. And in terms of the work we need to reinstate those areas, there's no building work required other than going down to Howden's and getting some new kitchen cabinets. Other kitchens are available, going into that. And this morning, the physiotherapists and occupational therapists sent me their list of required equipment that we're going to buy to kind of give that better rehabilitation offer going forward. So just in terms of the concerns raised this morning, we are absolutely investing into that asset care within Yeovil, and the rehabilitation offer should be much improved compared with their current state, where the gym facilities at the moment, they have to move equipment out of a room to use one piece of equipment and swap it around, whereas this is going to give us that dedicated rehabilitation space.
Could you give us the timescale again, please?
Yeah, so timescale for all the building works. Within Yeovil, we are planning to have that done before the end of the summer, so it will be before the full go live in September. We're tying it in with some window work where we're replacing the windows on level 9, and as we kind of change windows out, we'll be changing the purposes for room back for there. Within Musgrove Hospital, we have a series of building work, which at the end of May, we will have completed the new HASU bays, the hyperacute stroke unit, and then the refurbishment of the gym areas and kitchen areas, and the rest of the ward will be finished at the end of August.
Lovely, thank you very much. Did anyone else wish to? Just wanted to make sure that Andy Miller and Christian Wigan, Chris Turner were online, I believe. If you do wish to speak, please could you just indicate by raising your yellow hand, and then I won't miss you. Thank you very much. So in time, I'll just go to Councillor Trentnall, please.
Thank you, Chair. So, my first point, there's no question about the second recommendation. We absolutely need regular updates on this. I share people's concerns about the closure of this service in the Yeovil District Hospital. I was talking to one of my parish councils about this the other day, and one of the people in attendance is a consultant pathologist who said, I would put my wife in my car and I would drive her to the hospital. I wouldn't wait for an ambulance, and I didn't know he was a doctor. And I said, oh no, the advice is you call an ambulance. And he went, I'm a consultant pathologist, I know this stuff. I would be driving my wife there because the lack of trust in the ambulance service, the lack of ability, our road conditions, the fact that, you know, today 2 of us were late coming from Wincanton and Bruton because of the traffic problems, and I left in plenty of time, but because of the slowness of the traffic, these are big concerns. Now, I noticed that when this came to us ages and ages ago at Adults, when it was first sort of mooted, there was a mention of Royal United Hospital in Bath having a HASU. That's not included on these papers. There is a mention of the hospital, but it's not included on these papers. Now, where I am in Bruton, we're bang in the middle of Bath and Taunton and probably Dorchester. We're equidistant from all of them, I guess. But when you go further east in the county, so out to Frome, that would be the natural place for people to go. Now, unfortunately, I've noticed, and I might be wrong, maybe they don't have a HASU now, I don't know, but I've noticed that it's just been given a requires improvement rating from the Care Quality Commission, I think it was, because, not because of anything they're doing wrong, but because the sustained pressure on accident and emergency services. Now, if somebody is going in an ambulance, I think things are dealt with differently. If somebody is putting their wife in their car and driving them to that hospital and presenting, I would imagine that there'll be delay in getting that treatment. And so my concern is for my end of Somerset, being able to access that treatment. Some of our roads, if you get if it's in the winter, we've got terrible weather, trees falling down, all kinds of stuff that can hamper those journeys. I also felt that I needed to mention this issue that was mooted initially as the reason for this, the motivator for this, was the lack of specialists. And we've had this as well with maternity services and with other areas, that we cannot get people here. And I wonder whether, but I think we need to fight against just saying nobody wants to come here, nobody wants to come and work in Somerset, because it's true, my son is a doctor, he doesn't want to come back from Manchester area where he is now, but he's only one person. Is anyone trying to find out why we are unable to attract doctors, dentists and other professionals into this area to work? Because I think it's really important, because at the moment I'm thinking about a whole part of Somerset that is feeling as though they are going to have reduced access to services at a time when most need it. We're an ageing population in Somerset. We talk about it all the time. And of course, whilst young people can have strokes, it tends to be more predominant in older people. And I am deeply concerned, and I wonder whether you can reassure me that we're doing work on trying to attract people, that we could reverse this eventually if there were a case where we found that people living in other parts of the area that aren't served by these HASUs, if it shows that those people have worse outcomes, will it be rolled back? Those are the kinds of questions that I'm asking. And also probably the ambulance service, what should we be doing if we have a suspected stroke in our household?
Anyone, please?
So I'll take the Bath question. Ambulance colleagues on the call may want to respond. So in terms of IUH at Bath, it does still have a HASU. The current catchment areas, so the north of the county, already go to Bath, so the Broome area coming down. With the change from Yeovil, only a small number, so kind of around 20 a year maximum is in the modelling, will be going north to Bath. They have been involved in all of the clinical pathway process discussions, the repatriation to Yeovil for the patients who would normally have gone to Yeovil. They've been part of those discussions. So although they're not here today, because the way this change is going to affect them is very small, they've absolutely been a partner during the process of the planning going forward.
It's really about the quality of services and after the stroke, they are good. So you're right on the key. Guidelines for having hyperacute stroke are having at least 600 strokes.
Excuse me, 1 moment. We have a problem with the mics. People aren't picking it up online. Can you hear us online?
Speak up.
It might just be, it just come a bit nearer, but no one's answering me. Hello?
Hello, can you hear us? It's Chris Turner, Assistant Director for SWAST. We can hear everyone else, but the latest speaker we couldn't hear online. So there's something wrong with the microphone, I believe.
All right, thank you so much. Mr. Dr. Whiting, could you bring it even nearer to you, please?
That help?
Don't need to be too near it, but
Yes, I'm Dr. Rob Whiting, consultant stroke physician at Musgrave Park Hospital. What I was saying is that one of the reasons for being a hyperacute stroke unit is that it provides 7-day staffing 7 days a week. Specifications is that the stroke service is at least 600 a year. That's about having the critical mass, which will have sufficient staffing for it. There's also good evidence that units that have higher numbers of patients coming through, they get better experience. Challenge.
I just stop you just for a moment. I think it's your mic that's playing up. So we're just going to change you over as well. But if you can bring the whole thing nearer like this and then just go, but not speak too near it. A bit nearer, that's right. That's it. Thank you.
So that is challenges to
Can you just go a little bit further away from, yeah, sorry, apologies.
try and find the magic point.
Yeah, they think that the machine needs to be near, but you actually, you're just your voice, like you are gonna sing, that'd be great.
Okay, I can raise an octave. Trying to recruit now to be able to provide the 8 a.m. to 8 p.m. on the ground 7-day service. And that's important because it links to the point raised by Ray about time to treatment. But the ambulance service is doing their best to improve the time to get to hospital. I can see the ambulance quality indicators that have their few months. Six.
Apologise for us interrupting you all the time, but some people do have a deep voice and sometimes it can cause a problem. Councillor Trimnell.
Sorry, I'll try and make sure my voice isn't too deep. So my first point, I just want to say there was no query over the quality of staffing at Royal United Hospital in Bath, and also the recognition that these issues are caused by the pressure on services there and not by the quality of staffing. And so I just want to be really clear, there's no part of me that was saying that. But in terms of advice, should we be calling ambulances and waiting for an ambulance, or should we be putting people into our cars and getting people there much quicker? And I can see you shaking your head, but honestly, this was a consultant with 40 years experience, and that was his recommendation.
Can you hear me?
That's much better, yeah.
Okay, sorry. Like this. So, we know when patients are picked up by the ambulance crew, they're a very well protocolized process, which is swift in terms of assessing them, seeing is this a stroke or something else. But also within the changes we're making, we just convey them to the hospital. They're also contacting the staff, the stroke team at the hospital, so that we know about the patient as soon as they've been picked up. We can look into what their other medical problems are, treatments they have. So we are already in a position to know exactly what we might be able to offer in terms of treatment before they arrive. If someone's driving that person in their car, we don't have that information until they arrive. So it gives the team who are waiting to see the patient less time to be prepared to know what they're going to do. A further point, moving on from that, is that past the plan is to have stroke video triage, where the service, the patient, they can actually link it to the specialist in the stroke centre to see what's happening to the patient, say whether this is a stroke or something which looks similar to a stroke, and they can decide whether it's the right place to go to. But also having a better idea of how the stroke symptoms have affected them will enable them to so that's the effective, well protocolized ambulance service.
Sorry.
Yep, very quickly.
It is. So what is I believe it's a category 2 call out for a stroke. What is the waiting time, particularly for less accessible areas, like villages around Bruton and things that are already a distance away?
That's probably one for the ambulance service to be able to answer. Look to the most recent ambulance quality indicators, which said the median time for a category 2 response is about 30 minutes.
We have Mr. Turner, Chris Turner. Would you like to speak to it, if you can come in at that point?
Yes, thank you very much. Unfortunately, I didn't hear much at all of what was said because of the microphone breaking in and out, so I'm a little blind. Two questions I need to respond to. One is, should you call an ambulance? Absolutely yes, in a medical emergency. We would absolutely condone that. And we can do intervention treatment. We can do various other elements, as was mentioned, about preparing that patient ready for emergency department arrival, including direct to pathways where we can shortcut some areas of normal access that you go through a waiting room. So effectively, we're doing the triage beforehand. The next one about response times. Yes, strokes fall into the category 2 response, and they largely fall into the category 2A response, which is that you get an ambulance, it doesn't go through triage. And our average at the moment in Somerset is around the 30-minute mark. We are aiming to get to 27, but that is work in progress. But as I said, that is an average across the county over a period of a month. So at any given day that will vary, and where the incident occurs will also vary. We are a moving resource and a moving fleet. Therefore, the response might be incredibly quick and slightly longer, but the mean average at the moment is 30 minutes.
Thank you very much. Thank you. Thank you for that. Thank you. Okay. Can I go now to Councillor Bailey?
Thank you, Chair. Thank you for your report on the rehabilitation movement forward. I'd just like to applaud all the support I've had. I wouldn't be here today without the NHS. I've done heart surgery, a heart attack, and pacemaker. So I've got some skin in the game, really. That's not the point that I wanted to make. I'm still really, and I would applaud your intention of heading towards a higher quality service. But I'm really concerned about the times. I was always told and drummed into me was how quickly one had to get there when we need to, and I was taken by ambulance to Musgrove when I had a heart attack. And that still seems to me the real concern about how we deal with this situation. And I don't think it's been addressed with confidence for me anyway, and probably everybody else in terms of the timescales that are there. So whilst I applaud the fact that you're looking for an improved service, that's my concern still. The second point in relation to that really is that we had this conversation with the maternity units. I know they're different, but recruitment was the issue there. It's closed down and has been reopened as of April, as I understand. I haven't used it myself, obviously. And that was a recruitment issue, and that was overcome. And I would just hope that we could move forward on the recruitment issue and deal with a situation where we go, because it is quite a large area that we're now seeking to cover with people like me who would have been in Yeovil, but are now going to Dorchester, to Bath. I think Salisbury was moved as well at one time, and Musgrave, but I may have missed that out. So that's my concern, really. One is about the timescale. I've got another question which is associated in a moment about the timeline for getting people there, and also about recruiting people for working in Yeovil. So it's very similar to Councillor earlier on. That's my first point. The second one is that you talked about rehabilitation. I benefited from the support of Yeovil Heartbeat when I've been involved on several occasions, and they're absolutely brilliant. And I know by talking to people who I was in Bristol with, they do not get that service. Middle of Wales, nothing. So thank you. And I just wondered where Yeovil Heartbeat, because I have done quite a bit of fundraising for it subsequently, and I've benefited from their help, fits into the rehabilitation side, because I'm still involved with the nurses in that on occasions when it needs to happen. And one thing I would say, which I've never had in any of the services, they gave me, and it's now 2016, their mobile phone numbers when I went in there, and I've used them on 3 occasions. I've had concerns. They've answered the phone, and it's been dealt with the cardiologist at the time. So I can't applaud that sort of service enough, but I realise that it doesn't happen because there isn't a Yeovil Heartbeat everywhere. So my second question is, where does that fit into the rehabilitation side? Because I know they've done a lot of good work over the years, and I'm a recipient of that. Thank you.
So obviously, Heartbeat, I've got limited understanding because I've not worked with cardion.
Could you bring just the machine here and not your, just the machine? Thank you, that'd be great.
So unfortunately, I've not had experience of working with Heartbeat because that's within cardiology. Stroke rehabilitation offer is slightly different. It was being mainly provided through 2 areas. So firstly, within the acute stroke care unit, when patients return from Dorchester or from Musgrave, and then going into our community neighbourhood services when they go. Some people may need to go to North Everton or to Willerton for a further period of intense rehabilitation, depending on the level of stroke that they had. But the majority of them we picked up by our neighbourhood services going that way. And we've been working with those kind of follow-on parts as part of this programme to ensure a single flow. So one thing that One major change that we're doing is that there will be a daily call, 7 days a week, where when a patient first comes in for their hyper-acute care, everybody knows that that patient has arrived, so that we can then also plan the move to the acute stroke unit, and then the acute stroke units can plan the discharge home or discharge to a community hospital for a rehab, so that we're constantly looking at the flow to ensure the flow happens, but also so that the therapy staff within the community know that somebody's coming this day, we roughly know what the timescale is going to be for their acute bit of care, that they're ready and for the person to come on out. So we've kind of got that whole flow going through in this new daily multidisciplinary call with all 3 acute hospitals, the 3 community rehab hospitals, 2 in Somerset, the 8 in Dorset, and the community services as well.
We'll come back, Chair.
Certainly.
Slightly concerned that there isn't an integration with the overall heartbeat. But perhaps you could come back to the committee on offline with an answer, because that should be integrated. Certainly I was seeing before operation and afterwards as well. But I come back to the salient point, fundamental point really, or substantive point, sorry, of the timescales. And on the occasion I had a heart attack, there were 3 people who were picked who had it at the same time. 2 made it, I was one of them, 1 didn't. Vascular issue there. So that was what I was told afterwards. I can't corroborate in any other shape or form. But what I'd like to perhaps come back to is that when the data, and sadly this data is going to be people who don't make it, on the reference I just made, comes back, will you reconsider the situation that you've moved into in terms of your overall?
Thank you for your question. We will obviously, once we go in to implement the new model, we will be really forensically monitoring it. We met with a local MP last week who asked exactly the same question about what would our response be, which we said we would be absolutely monitoring the service. And we will obviously look to see what the implications are down the line. We need this to work. So if it's not working, we would need to then look at how we could make it work. But yeah, we would definitely be looking to make sure that it's doing what it needs to do.
Thank you. I just wanted to ask.
Quickly.
Oh, sorry. Are you coming back?
Yeah, I was just going to say, hopefully quickly.
Yeah, well, we'll be monitoring it throughout. Yes, we need to give it some time to bed in, and we will be making sure that all the clinical pathways are working as effectively as they can be, and making amendments as and where we need to. But yeah, absolutely, we'll be really forensically making sure this is working correctly.
The lack of dead body should be.
Thank you, Councillor. Thank you. We need to keep upbeat here. I think that one thing I did want to ask is there. I should have asked actually Mr. Turner, I suppose. But is it a factor that do we need more ambulances, or is it? Because I often wonder, is it? We've got the facilities when we get to the place, but I wondered whether it's the travelling too. My mother had a stroke some 15 years ago, a 4-day stroke, and she was provisional one at hospital, then another, and then went to Musgrove, who looked after her very, very well. And she unfortunately was so very, very bad, she had to go into nursing home, but lived 8 years. So in a way, 4-day strokes, not all strokes are the same, are they? Strokes are different. So therefore, it started out, she was fine, and then it just got, with the 4 days, much worse. But is it the ambulances we need? Is that an area? I think I want to know the area of weakness. What is the area of weakness that you can identify?
Thank you. Interesting question. So, of course, in a perfect world, we would have an ambulance on every street corner. That's something that would be utopia. But in reality, we know that that is not possible. What I would say is that what we're trying to achieve, and we're working very hard towards, is a streaming process where we get an emergency call in to our emergency control centres, and instead of historically dispatching an ambulance to every job, we go through a process of category 2 streaming, where we take some of our calls that are being deemed to be clinically safe to be triaged by a telephone paramedic, so that we take a proportion and it is around 20 to 21% of our call volumes into the hear and treat space, which means that we either refer to alternative pathways, but most importantly, we don't send a double crewed ambulance to. And then what is left, we then dispatch an ambulance to. Now, the question is, would we do with more ambulances? As I said before, ideally, yes, but what we have, we use as efficiently as possible. I mentioned before that our fleet are mobile, they're moving, so they may very well start at Taunton Ambulance Station, and through the course of their 11 hours, they may do upwards of 250 miles in a shift where they are moved from job to job, and wherever they book clear, they're the next nearest for an incident. So where is this leading? So we tend to think about Somerset as a county and ring fencing, but in reality, as a regional ambulance service, if one ambulance goes to Bath, for instance, from Shepton Mallet or Bruton, then the likelihood is that an ambulance from Bath has moved and is responding to an emergency in Somerset. And the same happens in Dorset, same happens in Devon. It is the benefits of being sandwiched between various counties that we enjoy those benefits more perhaps than somewhere like Cornwall. Or on certain borders of Dorset and Wiltshire, where they neighbour different ambulance trusts, or in the case of Cornwall, they have two coastlines. So we look to being as efficient as possible with the resources that we have, and making sure we maximise them through various call grades, category 1 through to 4, 5. And then the hear and treat element, and then the hear and treat element or see and treat element when a crew arrives and discharges on scene, to then have those then that are conveyed to hospital. Hopefully, it's described what is a very complex model in a few minutes, but it's not as simple as just having more ambulances.
Oh, thank you for that, Chris. I think what I wanted to say to you was, if you identified that weakness in not enough ambulances, which is a very difficult thing to say, and everybody, it's just like coming here, isn't it, saying you want more pay and you want more, you can't do that, I know. But what I'm saying is, if you'd identified that, then that is something that we in Scrutiny here can work on. So thank you for that information. I can see what you're saying now. Thank you.
Thank you. And I think it must be also added that we all work within the constraints of budgets as well. So most of our income goes on people and resourcing, being an ambulance service, of course.
That's when we put the budget at the highest level for yourself. So thank you. Okay, can I now go to Councillor Cameron, please?
Chair, I didn't see any mention of how these changes are going to improve health outcomes in the document. I was just wondering whether you could provide any data on what those health outcomes are likely to be. This proposal was looked at by Glastonbury Town Council on Tuesday evening, and there was a forlorn acceptance of health services moving even further away from the community. And I'd like to understand when the ICB is going to tell us how health services are going to be developed in accordance with the 10-year plan and the 3 shifts, because that's the positive message we need to give, but we don't seem to have that narrative. And I think this is about the 4th time I've asked for this whilst doing scrutiny. And I was wondering whether you'd be able to answer both those questions.
Yep.
So, benefits from having a 7-day hybrid stroke unit
Chair, forgive me. Question I asked was, how does this new service improve outcomes? I understand how it has to, and a fully staffed has to improve health outcomes, but I'm asking, how does this proposal improve health outcomes? Because surely you've modelled it, or you've gone into designing it.
7-day has to reduce disability, that's the aim. Awesome.
Thank you very much. Thank you. Everybody, Councillor Hobbs.
Sorry, Chair, I did have that second question.
Oh, I beg your pardon. I would never cut you off, Councillor Cameron. You know that.
I did ask the second question, and that was to do with the.
I'm happy to respond on that one, thank you. So you're absolutely right. Obviously, the neighbourhood health plans are going to be developed this year. So part of that will be absolutely going out, talking to and collaborating with people to pull that plan together. We are just, obviously, as you probably understand, the ICB is going under a major restructure at the moment, so that should happen within the next couple of months. We will then be in a much better position to be able to go out and meet with all the stakeholders in Somerset to start pulling that together. So we will be knocking on your door at some point.
Mr. Cameron, happy? I think what we, and I know, do you understand what Councillor Cameron, we want to know that this new model is going to be more efficient. We need to know the comparison, that you're going to meet the needs, you're going to feel happy. You're the people there that doing the job, and it's important that you feel this is working. And it's not an efficiency saving that actually in the end doesn't actually, might save a bit of money, but actually doesn't make your working day better. So I think that's a very important factor, what Councillor Cameron is trying to say.
Absolutely. I'm sorry, I was responding about the shift, the three and the neighbourhood health plan. So yeah, but absolutely, to echo your points.
Thank you very much. Thank you. Councillor Hobbs.
Chair, my concern is around timings for getting patients to wherever the stroke units are, to be from the Mendip Hills. My father had a stroke, appreciate some 18 years ago. He was blue lighted at Western Supermarket Hospital, 36 minutes. 39 minutes, so just taking timings off my phone. The Oval 50 minutes, Musgrave 58, Dorchester Hospital an hour and 21 minutes. So I share the concerns of Councillor Trimnall around representing a rural patch, being able to get people there quickly. It may take the ambulance to get to that location in the first place, because I can't imagine that many ambulances will be stationed off shift on Pretty Green, waiting for my dad to have a stroke. He's still here, by the way, nearly 92. So obviously the stroke services worked very well in saving the poor old chap, who's still just about around. But my concerns are generally around rural areas, seeing patients to the hospital, wherever it is in the first place. And you say, I think when you said over there that only about 20 people go to the RUH from Somerset. Yeah, give or take. So my concern there is representing one of the most northerly divisions in the county is, would they be expected, should my mother, who's still with us and still living in Pretty, have a stroke, where would she go to if she had a stroke now? Thank you.
I'm just going to jump one. I'm going to bring in the portfolio holder, Graham Oakes, please, for public health, because I do feel I'll come back to you, Councillor Power.
I'm happy to wait till after the committee.
No, come on. I want you now.
Thank you, Chair. Made my day. Very few issues I've ever been involved with that have continued to be something that I'm actively involved in. I don't know how long this is now. It's 2 or 3 years. But from when I was vice chair of this committee, and we considered a very, very long report about the introductions of HASUs. And since that time, and since the decisions were made, what's happened is that myself and other people have been looking at that and seeing how data unfolds. The problem is, and this is the problem we have today, if we had that report in front of us today, with the evidence we now have, we'd roundly turn around and say no. Now, what I'm not saying is HASUs are bad. HASUs are a brilliant idea, and they work. Do they work better in bigger hospitals than little ones? No, actually they don't. The evidence is different to what we think. There's been a lot of issues, and some things not mentioned. The importance of visitors in stroke care is incredibly important, and we've known that since the 60s. But we know that in stroke care, visitors being able to be there matters. Now, if you happen to live in Taunton, it's hard enough for you to get to Musgrove because of Taunton traffic. If you happen to live in Melbourne Port, Somerton, Yeovil, whatever, having that extra distance, that ever travel, we don't have. I love coming when I go to Taunton because it's got loads of buses. We play spot the bus in Yeovil. It's a rare game. I rarely win it. We don't have the public transport links, so we are reliant on friends and neighbours for people to go and visit. So it is an element. We were also told that the reason Yeovil couldn't have a house was it wasn't going to hit the 600 people per year. Well, sadly, I think we're moving in that direction. Steadily, the number of people having strokes in the Yeovil area is increasing. Not that far off the 600. And once we've solved the phosphate issue, we have all those new houses, we will do it. Now, I suppose what I should be challenging the health today is to say, as soon as we get the 600, are you going to commit to opening a HASU in Yeovil? That is the question, because the evidence will be there. That was one of the main factors why we couldn't do it. We didn't have enough poorly people. And like I say, unfortunately, we're in that. So that challenge I'm laying down, because if the case is that that's the magic number. The other thing was around, and this is the irony of it, this scheme is being delayed because of difficulty to recruit staff to Taunton. The reason we were told it couldn't be in Yeovil was we couldn't recruit in Yeovil. Taunton had a better recruitment record. That's what we were told in this room about 2.5 years ago, whatever it was. Actually, it turned out that we could recruit. We even had one too many consultants applying for Yeovil. The situation varies time to time. I have confidence in the way that the HASU will open because of the way that they've reopened the MAT unit, which has to be admired. The detail and effort put in. How we got there, I have concerns. But the way that this group of people have worked together to reopen Yeovil MAT unit is superb, and we're all very grateful that's happened. So I have confidence they'll open the Taunton one well. The problem is that this decision is based on I think it was 2014 when HASUs were invented, on an idea, primarily an urban idea. In Somerset, we have our own special way of doing things. Because we don't all live together, there is a problem. And travel time, and I listened to the comments. He's talking to a man who had a heart attack and had to wait over an hour for an ambulance. That's great. That's level 1, or what they call it. Over an hour, still here. Only because neither the devil or God wanted me, but I'm still here. And when I was treated in Yeovil and then in Musgrove from West End, perfect treatment. I thought it was absolutely brilliant. It was really good. We can have a philosophical debate about whether the HASU and then having Yeovil having an HASU is the right way to go. But that's all it really should be, because the only way that it really works is a HASU in both. The reason it only works that way is because the important call to needle time that we fail to meet at the moment, and although the ambulance service have improved, the 15 minutes at the emergency department's pretty irrelevant if you're a good 3/4 of an hour past the needle time. The reality is, in Somerset, our ambulance service needs more resources. May not say it publicly. We need more ambulance services so that people can be dealt with at the time, any point, 24 hours a day. They need to be able to get to the HASU, or at least to a hospital quickly. At the moment, we we do not do that consistently. The figures have come out, and I've had the figures for last year and the year before, and there's improvement. We're still failing to hit the target. So you can't actually, the decision you've made, I had concerns with at the time. The evidence shows that that decision was wrong. It was wrong because you rely upon an ambulance service delivering people within the time. Once you get to Musgrove, I have absolutely no doubt the staff there will do a brilliant job. Once you get to YDH, they do a brilliant job. But you got to get there. And nobody can give us that assurance. So the problem is we're kind of looking at it slightly in silos. I'm not criticising the people who are behind government's original plan. I think the HASUs are a good idea. And if we were in a position of opening a HASU in Yeovil and a HASU in Taunton, it would work. We could recruit the staff. It would be successful. I have no doubt that these people would make both of those units highly successful. The problem we have is a very simple one. You can have a house, you can spend all the money you like on it, all the top staff, but if the person's dead in the ambulance before they get there, all the damage is further done. You're starting further back down that road than you needed. But those of us who've worked in strokes know every minute counts. It does matter. So I know I've been quite critical, and I have been critical, and I continue to be critical of the process and everything else. But despite what the national evidence suggests, in Somerset, this is the wrong decision today. Two HASUs would be the right decision. But the most important thing, with respect to the goals of the stroke unit, is we sort out the ambulances first. If we do that, we solve John Bailey with his heart attack and me and mine, and you also all those people have strokes. So that is something. And what how this committee reacts, I don't know. I assume you'll just keep this under close surveillance and challenge. But I would like the commitment today. My challenge is when Yeovil hits that 600 number, which it will mathematically, even if they're going to Taunton because of where they live and the catchment area, are we now, will the ICB commit to opening a house in Yeovil as well?
Thank you very much, Councillor Oakes. Obviously, we're very glad that you have been saved, as with Councillor Bailey, because you've got some very good points, and we thank you for this today. Alison, I think that's a very good question. This was my question earlier about the ambulances, because I do feel if we haven't got the locality, at least if we had the ambulances to be able to get people there, this is why I asked that question, and obviously the officer came back with me. But can you just say to us, listening to what Councillor Oakes has said, is there any chance of having two HASUs?
Thank you for lots of your comments there. And can I just pick on one thing before I answer that? You know that people take time before they ring the ambulance if they're having a stroke. Sometimes it can be up to sort of 90 minutes before they actually phone an ambulance. So part of the work that we will need to be doing and part of the communications is not just about phoning 999 when you have a stroke, but actually phoning sooner, because the more people, you know, and I've had personal experience of that where a family member phoned me thinking that their loved one's having a stroke and should they phone an ambulance, and I said absolutely, get off the phone to me and please phone. So you know, people dither because they don't want to be a burden and they don't know whether they're doing the right thing. So absolutely, we really encourage people to ring 999 if they suspect at all someone's having a stroke, because we all know time is critical. With regard to the query around if the number hits 600, will we open a HASU? I'll go back to my previous point where we said we will absolutely be effectively monitoring the services as we go forward. I can't make that commitment today that we will be looking at that if we hit the number. We've obviously invested in a lot of recruitment on the Musgrove site. We've put a lot of time into the clinical protocols and policies that we will be implementing. What we will be doing though, as I said, is absolutely monitoring the services and making sure that they are working as effectively as possible. And if they are not, we will always be looking at what
have we made the right decision? Are we making the right decisions going forward? And we'll be reviewing constantly.
Thank you. Can I just go back to councillor Oakes?
Just very briefly, the strength of the MAT unit problem was that we've ended up now with a single team serving both sites. That there were there were issues with the Musgrove team and the Yeovil team. There's now one team, and that approach well, it's only a few days, but where is the way forward, and it will work. The second HASU would be one team. It wouldn't be, they would be one team, and where those consultants would recruit. It's not we have the model, our own model that works, we can follow. I don't doubt that. I actually need something a bit stronger, even if it's a no. I do need something a bit stronger than we'll monitor it. Yes, you'll monitor it because that's actually your job, is to monitor these things. But when the evidence is there that the magic number has been tripped, at that point, there needs to be a public situation where it's not monitoring, we're now considering at least. Otherwise, because if you're not saying that, that's quite a different situation to what this committee was told 2.5 years ago. When we were told the magic number, didn't hit the magic number. When we get that magic number, which we will, in the next couple of years, they've got to open a house for Yeovil as well. We can't have two-tier health in Somerset.
I think, thank you for that. I think that point's been very well made. I think we all understand, and I think you understand that. I think obviously you wouldn't know what the number is now, would you? You wouldn't have any, would you have any idea what the number is now at Yeovil? We are nearly there then. So it's be 600. So I get the point. So thank you for that. So I think the point I raised about ambulances, the point I raised about second HASU. So what we need to do is, I think monitoring is exactly what you're going to do. I think councillor Oates wants something stronger. So I think we'll have strong monitoring, okay? Because I think what we need to do is, this mustn't be forgotten. It's a very, very good point. And I think what we'd like to do is ask you to come back. I won't want to call you back anyway. I want you to come back very quickly because I think it is going to be, unfortunately, I'm sorry for the people of Yeovil that they've reached that, nearly reaching that figure as well. But I think it's very, very important. And I thank you very much for that question. I'm now going to go on to the much needed councillor Power, who I put back a moment ago. Thank you.
I think actually some of my comments have actually, what questions actually been covered, but I'm coming from a first aider's point of view, because I'm a duty manager at a leisure centre, and obviously we have a lot of elderly people coming up to do a lot of fitness after they've had surgeries, etc. So that some of them are quite high risk of stroke. But when we're doing our training, and strokes are saying every minute counts, we were told is face, arms, speech time, which comes up to fast. But for example, this is going to take 30 minutes for an ambulance, and I completely understand that, the constraints that you guys are up against. But from first aider's point of view, what would you suggest that we do, apart from obviously call the ambulance, but for making sure that, the patient's comfortable, etc. But it's just going forward, it is quite confusing from hearing, oh, we really need to act quickly right now. Oh, but the ambulance is going to take 30 minutes. It's just for the people out there listening, probably, on Teams. It's just.
So, important thing to do.
I think we did lose the sound a little bit there. I think it's your dulcet tones. I don't think it's anything wrong. I think it's just you have that kind of deep voice, and which is lovely. Okay, can we go to Councillor Sully, please?
Thank you. And I think it's really appreciated that you're all here, right? So this is an incredible opportunity to talk to you all. And how challenging is this, really? And I think that the frustration with the NHS as a whole is everything is sort of fragmented, and there's this part and there's this part. And if I have a criticism, it feels a little bit process driven, and the process sometimes is the goal. Having 2 medical emergencies in the last 2 weeks I've been experienced with a very good friend. The paramedics that came out, I was shocked by the paramedics that came out the first time, how experienced they were. It was like doctors, you know, that how thorough. And I have confidence, you know, the second set of paramedics weren't quite the same, but there probably was a different context because it was the second time they came out and they knew. It wasn't just that they had the equipment and they had the training and they were really lovely. It was the way they were thinking. It was like doctors in the room. Where it all fell down was A&E, sorry to say. And again, it isn't about individual doctors, but in Bath, there was corridor care and pit stop. Someone's made a decision to come up with that. This is what I mean about process. And I found it quite offensive. And we were in corridor care. We looked at gas. And every time I looked the way I did, I kept being given a leaflet that said corridor care. So my request is, please, can you not call it corridor care? We were in the way. I was in the way. I kept being told, can you move out the way? But I was with my friend. They don't have corridor care in Yeovil, you'll be pleased to know, because people just sit in their chair for 6 hours. My friend, when she went in the second time, was 6 hours. She was cold. She asked for a blanket. Took 6 hours to get to a bed. I believe the bed was probably there. I really don't think that bed wasn't there. So while we got you here in the room, I hope you're listening. I don't want to sound disrespectful, but you're really listening. The numbers game feels like a process. It feels a bit cold. We don't know the entire picture of that, you know, with your constraints and the way you're pulled in different sides. But please listen. I will never go to A&E unless it's my life is on the line and I don't have a choice. I never want to go to A&E, and because I feel your time is being wasted there. There should be a better way. And this, I think this links, I know this is probably going, I don't want to say doing a U-in, it sounds really unfair, doesn't it? But I think it links because look at the whole here. People brought up about ambulances and paramedics, but I have to say, I was shocked in an impressed way about how good paramedics are. And in my experience, but A&E is a problem. We're all going through this funnel, which pit stop, please can you tell someone who came up with that name? It's not pit stop. You're there for hours and it's not corridor care. It isn't care in a corridor. Thank you.
Thank you very much. Thank you for that. My own husband, who recently had to be 9 hours in A&E, but I have to say they did, because he couldn't stand in the end, they put him on a bed, which was very kind of them, in the own doctor's office, which I thought was over and above, really. But if these things happen, it was a very busy night. And you know what? We can't expect people here to invent water. I get it, you know, but it's very, very important. I want to go to Councillor Bailey, and then I'm going to go to Councillor Trimble as the last speaker, unless anybody identifies right now. Okay, so I'm going to go to Councillor Bailey. Councillor Bailey first.
Thank you, Chair. Listening to the debate that's gone on, there seem to be, and I was just going to propose, there are 2 parameters which really have come to the forefront. One is the 600 figure that Councillor
Oates, yeah.
So I used to call him Grant, was talking about. The other is the timescales of arrival at the unit versus the current situation, therefore the change. And I would just hope that we could actually have the sort of direction of travel in those, not in 6 months' time, but sooner than that. They must be figures that you're holding and keeping. And those 2 parameters, I would just personally feel that what seems to be the nub of the discussion that's gone on today. And if we could have that direction of travel, then we'd either be confident that things were going in the way. I know there are other things like the disability reduction and all that sort of stuff. Just from the discussion from, lay persons, or whatever we're supposed to call them nowadays, the 600 figure and the timescales that we're concerned about are the two. And if they're moving positively, then, that would be a good thing. If they're not, then we'll hopefully have a discussion about what might be done next. So my proposal would be to look at those two fairly soon.
Thank you. Just excusing councillor Sully, it is an urgent issue. Okay, so please forgive her for having to leave like that. Councillor Trimble.
Thank you. So I've got a couple of questions. Firstly, I was trying to look through. We had ambulance performance times come to the committee at some point recently, and I can't find it. I've looked back through, but you can never find what you want when you're looking for it, can you? And so I just wondered I don't know when they're coming back, when we'll get another performance, but whether it was possible to get the figures just beyond that median time. If you're looking at the upper and lower quartile, those outliers, particularly the longest waits that people are having, and also how does that tie in with regions within Somerset? Are we looking at those? It seems logical to me that it will be the more rural parts of Somerset where people wait for longer. In Bruton, I live on the A359, see lots of ambulances go past, so we're definitely served, and I think served well. So I'm not making complaints, I'm just saying that sometimes it can be tricky. I was intrigued to find out to read about the fire safety issues on Ward 8B, because I think I might have spent several weeks there over time. And I just wondered, is that reflected throughout the hospital? Is that a one-off issue? Is it resolvable? So that's something I wanted to ask about. What will be done if you're going to use floor 9 now? What's happening to floor 8? And I think it's floors, isn't it? Floor numbers. And also, would we have the capacity at Yeovil District Hospital were that number of patients to increase to a number that justifies having that housing? Is there the capacity to scale up those services? Will there be a space to move it into? Because the problem is, once you use a space for something else, that space is gone. So those are just quick questions.
I'll answer
Thank you.
the fire one. So the fire issue is due to the building safety regulations, which is also known as the Grenfell Act. So it's a new Act of Parliament that came in following the tragedy at Grenfell, which required all tower blocks to have, before any building work can happen in tower blocks, you've got to have a modern fire system. And you can't do building work without that modern fire system. So as a trust, we're doing a complete review. We're working with NHS England, as are all hospital trusts around the country that have got tower block hospitals, as to how we improve fire safety to meet the modern standards. Because rightly, the Grenfell Act, before you do building work, wants the latest fire standards. That Yeovil Hospital was built in 1969, and so we've got some work to do. So there is a whole separate programme looking at how we can make the hospital compliant with the latest fire standard things. Because that's a huge piece of work, because it will affect the whole tower, it would have delayed the work that we wanted to do and give some rehab offer in the stroke programme. So that's why we looked at this alternative. But there is a programme to kind of address those. I think it's also important to know, just to give the committee assurance, is that up until the very last reading, hospitals weren't included in the Grenfell Act, because unlike an office tower block or a residential tower block, hospitals are manned 24/7. There's always people there that can respond quickly if there was a fire. But it was added in on the second parliamentary reading, right at the last, and so the NHS as a whole is having to kind of look at, well, how do we do this, because it wasn't expected to be in the Act. But there is a strategy. We're working with NHS England on it, but because it's going to take us quite a while to kind of work through that work, we didn't want it to delay the stroke offer going forward.
Okay.
Thank you very much.
The other bit?
Oh, sorry.
Sorry.
I'm sorry.
So there was the question about the ability to scale up and whether we could have the figures for those ambulance responses.
I'm going to
roughly
do
on
that separate.
median.
I was going
Sorry.
to do that separate. Sorry.
COP.
I think this, don't worry, I think the moment in time, I think the committee has made it very clear. I think today, and the summing up that I'm going to do, we do note the reconfiguration of stroke services. We do want further updates. We want them sooner than later. And what we do want, I want to add to the recommendation is the good point from Councillor Bailey that we want the direction of travel. We want to know the direction of travel. I want to know the improvements. Is it working better? But the thing I think we would like to, Mr. Chris Turner, I think I would like to ask anybody from the ambulance service through you, Andy, if that was okay, perhaps to come back here. We need to know that there is a good ambulance service out there. You see ambulance chasing around from one area to the other, and I wonder whether that is, we need a good ambulance. We need more ambulance, and maybe that's where our budget should be on helping you. I don't think this committee is not about us listening to you and then forgetting it and you walk away and come back again. We want to be an action group. And I think the action we've found today is that we want to know if you need more ambulances, if you think the requirement is there. And I think we need honesty. I think we need direction from you. So I think I'd like to add that to the recommendation that we need to have the ambulance response times come back to us and the amount of ambulance required. Would that be okay? Add that to the recommendation, Jack, because I think it's really important. And what I would say is perhaps when would you I think we need to know when you're going to come back, when you think the most appropriate time, 3 months or 6 months.
So we're happy to provide obviously an update on some of those areas that you've asked for. We'll provide you with a written response on that, Chair. And I would suggest that we come back about sort of after we've implemented in September, so we can give you an update on where we are. So if we could leave it sort of perhaps towards the end of this year, calendar year.
Okay, so probably October, the October meeting. Yeah, I would like the written update, obviously, of course, absolutely for all the committee, please, a written update. But I think we do want you back. We do want you back with those absolute, and I hate to say this, I do hope it doesn't happen to Yeovil. But if they are reaching then the 600, then we need to have some answers on the 600, because I think that would help us. I think we are with you. We're critical friends to yourselves. And if there's a weakness there that you need, and you do need more ambulance service, and you do need this service in Yeovil, then we've got to help you get that to make the life easier for yourselves as well. So I don't want you to think you've been battered today. Please don't think that. It's about us working together to make things better. Okay. So I'd like to thank you very, very much for your time today. Absolutely, because we couldn't do it without you. Really appreciate it. So thank you very much. Thank you. The next item on the agenda is the Public Health Programme of Works. And I believe Alison Bell was going to be here, but I think it's now Graham. Am I right?
I think she's here invisibly.
Ah, she's invisible.
Virtually, or whatever.
Alison, virtually. Hello, Alison. Thank you.
We live in exciting times, and yeah, Alison did plan to be here, but something urgent's come up that she had to deal with this morning, and luckily people like me have waffled on so long enough that she could actually now join it online.
I knew there was a purpose. And could I just, before you go, can I just thank our visitors for coming today? Apologies about the microphone, but thank you. And I'll be in touch with you, Mr. Herring, okay, about our other issue. Okay, thank you very, very much. But thank you for your time. It is appreciated. Thank you. Thank you.
So Alison's going to take us through this. Sorry, the Director of Public Health is going to take us through the programme of work, just so I can remind councillors it is in the report. But the way that public health is funded is largely by a grant, and that is specifically can only be spent on public health issues. Those are split into two forms. One is statutory things, and the other is non-statutory. And you look at that list, you may wonder why some of those non-stat things are non-statutory. They certainly should be statutory. But anyway, we don't have the issue of where we can go in and take money out of public health and stick it into adult services or children's services or whatever. This money has to be spent in this way. However, you're going to ask some questions about detail, and in that point, that's exactly why we've got Alison here. So handing over to Alison.
Okay, good morning or good afternoon, actually. Thank you, Councillor Oakes, for the introduction, and apologies, Councillor Slocum, for not being with you today. We have some very important national visitors with us and we needed to front up. The aim of this report is really for transparency. We want to share our public health programme of work and how we're spending the public health grant that the Department of Health, as Graham described, gives to Somerset with Scrutiny. And why we're doing this is we want to take a different approach this year so that we are seeking endorsement from the executive that they will delegate authority to implement this work programme to myself and the relevant portfolio holder and the associated spend, so that we don't fill agendas with process, which I heard from members. You're not very keen on hearing about the process. What you want to focus on is outcomes, and that is music to my ears, because actually what we should be looking at is where our population health outcomes aren't good, not just the noise of decision making and process. So I will be brief. As Graham described, this is the background to the Ring Fence Public Health Grant. So as he said, it's a grant from the Department of Health and Social Care. For 26-27, it will be just shy of £28 million. And some of that is ring fence for drug and alcohol. Some of it is ring fence for stop smoking work. Some is ring fence for gambling harms prevention, and all of it is ring fenced for public health. We are subject not to an inspection regime, but an annual visit from the Regional Director of Public Health, and he focuses on the outcomes we achieve for our population and where we're investing that money, and if it's giving us a good return on investment, a good outcome. One thing that I think it details in the report is how much lower Somerset's funding is than national funding. I think we receive 63% less than the average grant per head of our population, but we still have to deliver the list of services, next slide please, that every public health team has to. And a slight tweak to what Councillor Oakes said. So we have to do all of these things. The prescribed functions, which are NHS health checks, sexual health services, public health advice to the NHS, health protection assurance, and what we call the Healthy Child Programme, including NCMP, but you would call health visitors and school nurses, we have to do in very prescribed ways, and there's very little flexibility. The non-prescribed functions, which are drug and alcohol services, stop smoking services, oral health, not obesity, but ideally obesity prevention, promoting physical activity and promoting mental health, we must pay attention to those areas and improve the outcomes for our population. But how we do it is down to local need and determination of how best they are delivered. It is interesting having a ring fence grant for a non-prescribed function related to drug and alcohol and smoking, but that is the national decision. So if we go to the next slide, what I wanted to share is what proportion of the funding we spend in each of those areas. And what you will see is a big proportion of our spend is skewed towards three services: the drug and alcohol service, 25%, the sexual health service, which is 14%, and then our public health nursing service. And what I would describe at least two of those as is really quite clinical services. We fund the drugs, we fund contraception, we have to fund all these things. And so even though the grant seems like a lot of money, a lot of it is still spent on curative treatment services. And then if we just go to the next slide because of time, I've just got a little pie chart that just gives you that pictorially, so you can see the proportions and the actual amounts. And then if you go to the next slide, because what does I don't know, physical activity buy us? What do we do with that money? Some of these are process indicators, some of them are outcomes, but in terms of physical activity, can't remember what the spend was. I'm just going to have to flick back to my slide. So physical activity spend is about 215,000, and in partnership with services we commission, that buys us about 6,000 attendances at health walks every quarter. So we get pretty good value for money, I think. But actually, what you were talking about before you have to listen to me was actually our stroke numbers. And if we want those people who are affected by stroke to reduce, not increase, we need to work a lot more upstream, and we need to shift investment away from clinical services and reactive services and much more upstream into lifestyle and the wider determinants of health. And you know I always go on about that. And so if we just go to the last slide, what you will see is that the recommendation Scrutiny is asking, or I'm asking of Scrutiny with Councillor Oakes, is that you have a look at this, you read the report and you give us feedback on our work programme and the budget. I'm very happy to answer questions, and then we'll move forward to exec delegating the authority to us as a team to get on with the work. So I think that's all I wanted to say because I'm conscious of time. Happy to take questions, and I'm hoping I'm not projected on the big screen in the Sedgemoor room, but I have a horrible feeling that I am.
You're
So
all
you're just
right. You're on the small. Oh, you are now. You are now. You are now. We've got you. We've got you now. Alison, before I put it to the committee, I need to ask you. Some of the figures don't add up to me. Not being a mathematical genius, but I just wanted to say, with the 27,939,552 is the actual, and taking out the two ring fenced items, which is 8,478,447, it leaves us short in the budget, according to me, 8,478,507.
I am assured they all add up. I will take an action to double check that, but it does all add up.
It doesn't add up to, I've done it 3 times and it doesn't add up. That was where I was concerned, because the ring fenced items are taken, are within the 27 million. I'm right, aren't I?
They are, yeah.
Yeah. If you take that 8,478,000 out of it, it leaves you 8,478,507 short. All right. So
Jill, I'm not going to try and do the maths now. What I suggest is I double check and clarify for the committee, because the purpose of this was absolutely to be transparent. So if it doesn't add up, then we will ensure it does.
Thank you so much, because it just, I'm not, like I said, I'm not a mathematical genius, but it came very apparent to me. So I thought if it comes to me, then somebody else is going to have seen that, I think. So if those figures could be checked, I'd appreciate it. Thank you. Right, members, is there anything you'd like to add, please? Councillor Trimble.
So it was just a quick point that was similar to Jill's, really, Councillor Slocan's, that the budget used to be 21 million when I was there. It looks as though it looks as though it's gone up, doesn't it, by that headline figure. I didn't do the maths, actually, Councillor Slocum, so well done to you. But I did look and think, well, that looks like the actual public health budget is smaller. So it should not be smaller than 21 million plus those additional funds, which we've always received, but I think this is part of a longer term funding agreement. Is that right? And it looks like it's just all rolled into one public health budget now. Please let me know.
Yes, so what has happened from April 26 is, historically, as you described, Councillor Trimnall, is we had the public health grant and then we had lots of separate bits of money that all had different reporting and different metrics. So they've now put all that money into the 27.9 million, and some of it is ring fenced and some of it is ring fenced. And I'm just looking at the pie chart. They are all reflected in that pie chart, so it should add up. So yeah, I can't explain why the numbers don't, but yeah, so it's gone up in real terms. We get about a 1.5 or 2% inflationary increase in each year, but on top of that, the grant has gone up because they've put the external grants into the whole grant. Does that make sense?
Yes, it does. Thank you. I didn't know we had the pie chart unless I've missed it. It was a supplement and I didn't see it. It was a supplement and I didn't see it. Yeah.
I don't think it was on the public papers, was it? That just a presentation. That was all it was. So sorry about that if you haven't got it. All right. I didn't do it by the pie chart. I literally did it by the figures that were in the report. So I'm sure I've got it wrong. I'm sure I've got it wrong, Alison. So don't worry.
I'll come back to you. I'll come back.
Thank you very much. Can I speak to Councillor Govia, please?
Yeah, thank you, Chairman. Yeah, I just really wanted to highlight how important this work is. We constantly recognise that we spend an awful lot of money, when we've talked about it again today, on stroke services in district hospitals and that sort of thing. And of course, that's incredibly important. But Alison's alluded to the fact that it is really important that we try to move the money around within the NHS to move into the prevention side of things, because at the end of the day, you know, it's been said several times this morning, we've got an elderly population that's growing in Somerset, and you know, we are constantly trying to deal with the issues that the failure to provide adequate prevention has created. So I think it's incredibly important. This amount of money is, and I think the other thing that Alison highlighted when she talked about the health walks was how cost effective this work is in actually, you know, the amount of money, you know, we spoke about on the health walks, you know, it's very small amount of money, and compared with, you know, that would probably be spent in a matter of a few minutes within a general hospital. So so I think it is really incredibly important. It is always very difficult because us as politicians, we always want something nice and shiny to point out, like a new hospital or a new clinic or something like that. But actually, you know, at the end of the day, those things are important, of course. But the real goal is to get, as we've said, you know, the further upstream of the prevention work. And you know, I think we as a committee need to keep banging that drum and make sure that I know the executive know this, and Graham's been nodding a bit when I've been saying some of these things, so I know that. But we just need to keep making the message that prevention is better than cure. I know it's an old cliche, but actually it is really important, because it is very often the case that we divert money into caring for people, and actually if we could put some more of that into prevention, it would be much more cost effective. Thank you, Chairman.
Thank you. Thank you. Listen, could I just ask you a question on the health protection assurance? You've got an amount there for infectious disease and surveillance and control, and then you say staffing spend not captured here. How does that work if it's not captured there?
Okay, thanks for picking that up. So first of all, if I describe what health protection assurance is, so we've got a lot of things that pose a threat to the health and well-being of our population from an infectious disease perspective, but also Hinkley Point in terms of radiological and also chemical threats. So my job is to make sure that the threats of those infectious diseases and the chemical hazards and the radiological are protected. And we do that by looking at the screening and the immunisation data. We check all the emergency plans. We actively prepare for Glastonbury Festival and Hinkley Festival every year, and when there is an emergency, and you will see there are a couple of global emergencies going on that have public health implications, we are a category 1 responder, and so the budget is tiny, but the staffing, which is 1 full-time staff member, is included in that grey segment, which is miscellaneous public health spend, staffing and operational costs. And so the public health specialist team is captured within that, because it's not split according to individual lines, because most people don't just do one thing. So the Meg Coakley, who many of you know is our health protection manager, her staffing costs go under that miscellaneous budget line. I hope that helps.
Oh, thank you. I hate miscellaneous. I always have done, do you know? I've got this thing about miscellaneous. I don't know what it means, so I've always liked to delve. So thank you very much for that. Does anybody else wish to say anything at all? Anybody? Everybody? Okay. So thank you, Alison, for this today. I want to add something, if I may, that the recommendation has been to the Adults and Health Committee reviews and comments on the proposed programme, which we have done, and endorses the executive programme of work and delegates authority to the Director of Health in consultation with the relevant portfolio holder to implement the approved programme. Could I also add, with it copied into this Chair and Vice Chair of the Adult Social Care Scrutiny, please? Would that be acceptable?
I'd probably have to take advice unless community governance can advise, because what we're asking for is the exec to say that the lead member and I will enact the work plan that has been signed off. If we then have to copy you into every piece of work we're doing, that kind of undermines the principle of us being transparent, telling you what you're all doing. Of course, you can call in any pieces of work, and if there's any areas of concern, we would be more than happy. But I don't think it's going to work if we copy you in to. I mean, obviously, if it's a key decision, we consult with the opposition member and the chair of scrutiny. But for business as usual, I can't see how that would work, if I'm honest. But I'm willing to be advised by community governance colleagues, or we can take it offline if it's a monitoring officer decision.
Can somebody give me some advice then, please?
Thank you, Chair. Yes, in agreement with Alison, what she has said, as a decision as such, there is no requirement for copying in the scrutiny. However, as a best practice, it will be, of course, with officers to keep informed the chair and the vice chair of this committee about any future work.
Thank you. So sort of half and half there. Yes. A little bit when necessary, is it?
No, it doesn't really, Chair, it doesn't really have to be put in recommendation or decision.
Okay.
What I'm saying is what Alison also confirmed, that obviously opposition leaders, as well as the relevant chair and vice chair of scrutiny, will be kept informed about ongoing work.
Okay, thank you very much. Okay, well, I think that we all agree with the recommendation. Well, Alison, obviously, after those figures have been checked, I would appreciate that. Just a confirmation of that, please. Tell me where I've made a mistake. And but with the mistake ratified, sorted out, I think we all agree. Everybody's in agreement. Everybody happy? Can you just show our hands, please? Thank you very much. Everybody's happy. Thank you. Thank you, Alison, for being here. And obviously to Councillor Oates. You didn't wish to add anything, Councillor Oates?
I wanted to make a comment about yourself, but I couldn't think of anything quick enough. Something nice, because you were very nice to me earlier.
That's very kind. I like being nice to people. I do try. Thank you very much, Councillor Oates. Okay, item 10 now. This is the last one on this today. This is the committee work programme. We always our forward work plan. In July, we're looking at tenancy strategy. We're looking at the executive lead report, the housing task and finish group recommendations that will come in, as we know. The thing I would like to add, excuse me, I would like to add the ambulance response time, whether we can get somebody to come here in that time, please. I think it's really imperative. And the configuration of the stroke services will come back to us in October, okay? That would have been October, but I would like an early intervention on the ambulance response times, please. And if we can get, I didn't say goodbye to the gentleman, but we can get Mr. Chris Turner, perhaps, and his colleagues to come back. I think that would give us a greater understanding. Oh, sorry, hang on. Two people. Councillor Power.
So I can't see look at the work program, but is defibs on there at all? Going well.
No, they're not. So
Yeah,
you're
so
supposed
no, it's not recently, we're just going forward just to monitor.
yeah, I think we were. We had a we had
Yeah,
a,
I know it,
we had a report in February about the DFIBs.
yeah, it's just going forward.
Going forward, we can put them on the list, if that's okay. I can't see you.
Thank you, Chair. We have already asked the South West Ambulance Service to provide us with their improvement plan, which will include all of the timings. So I'm just wondering whether you could let us know where we're at with jogging them on that. So I don't think we need an additional request asking for the same thing, Chair.
No, it's not on the list, so it's not there. That's why I've asked for it. It's not on the list. For some reason or other, it's not on the list. Yeah, sure, yeah.
Thank you, Chair. Yes, we do have, Helen and I were discussing the work program, because we tried a little bit to, consolidate all the items in order to put, forward and suggested by the committee. And I see that the Southwest Ambulance Service Improvement Plan, it's not, Helen, you were told that it's not available, yet. But what we will do, we will communicate with the Southwest Ambulance Service and say that I looked at their website actually, and I can see what they want to achieve. They don't say how they want to achieve something. So it will be something that we can communicate with them, including the response times as well, so they can put in one report. But with your permission, Chair, we can check
Yes,
when
please.
is the best, you know, to
Yeah.
think.
I mean, I'd like them in July. Sorry, I'd like them to come in July so we can put those two things together. Because you're absolutely right, but they weren't on the list when I saw them, so I thought, let's get them back. Because I think that is an important factor for us to move on with. You will see that the August meeting was moved, we've moved now to September. Mainly because obviously it's always a very good, for those of you who are lucky to go on holiday, not bitter. We thought it'd be much easier to have that moved and then we have the September, which is much easier for everyone and it stops things messing around. So there would be a September and an October together, okay? So, and then. I'm sorry? Oh, at least, Councillor Trimmer, sorry.
Sorry, I didn't mean to interrupt. All I was going to say was I couldn't find when the ambulance service came and they gave us all their response times. And I thought that was an annual update. I seem to remember that they were due to come back, but I can't find it in my record.
No, it was October, it was February, so we'll get them back anyway.
The
We'll get-
ambulance service
Yes.
was February.
February, yes.
Oh, it was longer ago than that. Well, but that wasn't the response time.
That was response, that's not the response, I want the response.
Yes, okay, yeah.
So I'm gonna nab it all into one,
Brilliant.
okay? Is that all right? Okay?
Councillor Trimble, I asked a supplementary question about ambulance response times during the DFID. It's where they then said that they would come back to us with the ambulance.
So I want so we're gonna chase that because I want the whole thing, okay? We wanna know, we wanna be able to talk to them so that when the stroke service comes back to us, we've got some understanding, better understanding of where we are, how good they are, and whether it works in with what your Councillor Oakes wants is, has very diligently asked for, which I think is very, very important. And I thank you for that very much. Thank you. Sorry, I've got Edric, Councillor Hobson, Councillor Bailey.
Scrutiny, Chair. Sticking.
I think what we're asking whether we can do the DFID training and perhaps the task can finish. Maybe we can add, I think to add it into a main committee at the moment, we're too busy. But I think I'm going to try to get it in, but I won't forget. The DFID training is very, very important. And I think that we want to do that. Does anybody else have any comments, please? Oh, sorry, Councillor Bailey.
Yeah, I was just asking when the outcome tracker was on this programme.
The outcome tracker. We've talked about.
Will it just be another item which says to follow?
No, it's not going to be on every meeting, is it? You said.
You know, when will be completed?
Oh,
When will I see it for the first time?
Chair, it will be ready for next meeting.
Ready for next meeting?
Yeah, July, okay.
Yeah, we've got.
Yeah.
So I've written that down, so it must happen, okay? Okay, for those of you that are going to stay on for the task and finish, we're going to do this, but it's going to be starting, it's going to be a working lunch starting at 2 o'clock. And then it will finish at 4. I'm not doing a 3 hour, not with the heavy load we've had today, okay? So I do respect the fact that you've taken a lot of time. But we're doing, the telephone finish is starting at 2 o'clock. So those of you that have put your names down to stay, look forward to seeing you. Thank you.
Thank you. I used to tell my kids off packing up early in class.
That's it.
Yeah, Councillor Palmer, could you sit down, please? I'm just going to now declare the meeting closed. Thank you. Thank you for your attendance.